Okay. So obviously the last questions I have are the math problems. I guess just like tips for this, especially if you're not like a math person, is that she might put in the question like the word drop factor, and she might not like how ATI may put like the drop factor is GTT per ml or whatever. So just know if you see in the question drop factor 10, drop factor 20, whatever the number is, that actually would translate to 10, let's just say it's drop factor 10, it would be 10 GTT per milliliter, and you're solving for GTT per minute. So if you see a drop factor question, your answer is in GTT per minute. And she also said when it came to the other math problem, like when it came for like solving with the example of heparin, is that you always want to use like the antibiotic solution or the IV piggyback solution. You never want to use the regular fluid. So they tell you like something like isotonic solution, like normal saline. That's not the number you want to focus on. You want to focus on the medication. Those are just some things that I remember her saying. So just to like point that out. Okay.
I have a question regarding the math
Mm-hmm.
because I like when she was doing the math, honestly lost my brain cells because I was going according to like ATI, all these years that we've been doing the math. And from what I understood, she doesn't want us to convert the 30 minutes into the hours, even though she was asking for the hours. So are we just supposed to just solve it like the way she wants us to solve it?
It doesn't really matter how you solve it as long as you get the right answer. Sometimes I drown out things because I know how to solve it my way. And if you get
Right.
the answer, but it's the answer will be GTT per minute. So if it is hours, there is going to have to be some sort of conversion. So I
Mhm.
would say, yeah, you have to convert. Maybe she doesn't like didn't understand our question fully, but in order to get those questions right, it has to be GTT per minute, and the hours wouldn't give us the correct answer. It's like when you do the questions on ATI, right? Like you have to convert the hours to minutes, or else it's not GTT per minute, it would be GTT per hour, and that's not what we're solving for.
Right. I think she just confused a lot of us with the wording. That's why. So I was like, what are you talking about? But okay.
Yeah, I definitely think sometimes verbally hearing the problem just gets really confusing, and then people shout answers when they get it, and I had no idea what was going on. That's why I just mentioned those like few little points for the math problems, is that when you get the drop factor, even because she might change the problems a bit. So if it doesn't say like, oh, 10 GTT per mil, right, in the question. No, if it just says drop factor in the question, where that you have to use GTT per mil, but we're solving for GTT per minute. I know that sounds kind of confusing, but I just wanted to like point that out there because she was just saying drop factor of 10. And for us, we're like, what does that mean, right? But that means GTT per milliliter if it's written like that inside the equation.
Okay. Thank you so much for explaining because, you know how she is. Thank you.
Yeah, I know it could be confusing. That's why I'm like, if you hear that or it's just written like that, think, okay, in the question it's being basically represented as that, and my answer has to be somehow GTT per minute. So I have to figure out a way to cancel out everything to get it. Um,
Thank
Alicia, I
you.
want to ask you a question. For the second calculation answer, was it 100 units per hour or 1,000 unit per hour?
I think it was 1,000. When I asked the group chat, they said the answer was 1,000. I think she accidentally said 100, but mathematically it would have been 1,000. I don't know.
I think it's 100 units per hour.
The question that she gave?
Well, based on what I have here, and the answer was 100 units per hour.
Was it? I don't know. I didn't really hear the answer, but when
But
you
she
solve it, it
said
comes out to a thousand.
it comes out to 100. It says calculate. This is what I have based on what she said. Calculate unit heparin per hour. How many units will they get in an hour? 2,500 units in 250 D5W at 10 cc an hour. So I don't know. It equals to 250 per hour. This is what I got. So I put 2,500 units over 250 mLs times 10,000 ml over 1 hour, over an hour it comes out to 100 unit per hour, unless there's something that I'm missing.
I mean, I don't remember the exact question, but I think it was 2,500 units, right? And 250 D5W at 10 cc an hour, right? So you're
Mhm.
trying to solve for units per hour. So the way I would have done it is I know, okay, there's 10 cc per hour, so I would have put 10 milliliters over 1 hour times, and then I would have said, okay, well, I need to have units, right? So I have 2,500 units on top and over 1 times 1 over 250. And when you divide all that, that'll get rid of the milliliters. And 2,500 times 10 is 25,000. And then 25,000 divided by 250 is 1,000.
The first time she said that question, I understand why we were all confused. She at first said 2,500, but she meant 25,000. So if you check the chat where Sahar put it, the problem was what she wanted you to do was to take the 25,000 units of heparin, divide that by 250, and then multiply by 10. That's how you get the 1,000. It's just her wording.
Yeah, but the answer was 1,000, right?
Yes, yes.
Okay, yeah, so it was 1,000. Yeah, okay. Um, so maybe she said, I don't know, sometimes she says different answers, but like if you just know how to solve it, like it should be like a simple, like, okay, this is the units, right? You have to cross out things to get units per hour. So the answer should have been 1,000 if it was done that way. And
Yeah, the thing is that I probably missed that zero because of her explanation, but now I get it. It's the I missed a zero to the
it's
25,000.
okay, it could happen. I just wanted to clarify that. And I'm happy you brought it up because now we know it's 1,000. So if you're looking back at that question and you're
Yeah, I was like,
uh,
where am I missing? What am I missing that I don't see 1,000? But now it makes sense that
yeah, it's
zero.
definitely 1,000. So if you got that, then you know how to solve them. You just have to wait to see the question. I don't think they'll be as hard. It's just I think the verbal explanations is what confused everybody. And like if you
Yeah.
didn't hear 250 and you heard 25, you can get a different answer because just the way it was said verbally.
Thank you, guys. Thank you.
Okay, so I'm happy we went over that because hopefully those are going to be 2 additional points that we have, right? So we know going into the test we have 2 out of 60, right? That's pretty good, or no? But like still, it's better than none.
Yeah.
Um, but okay, so starting with chapters 62 and 63, the first question is to provide education about COVID-19 and risk factors. What I had that Dr. Remy wrote was that you're at a stroke risk when someone has COVID-19 and it puts you at risk. I did a little bit more research. It specifically puts you at risk for ischemic stroke. Um, so I don't really have much more to that other than there's some abnormal clotting when you get COVID-19, which could happen, and as a result, you can get ischemic stroke because ischemic stroke means something is blocking blood flow somewhere, right? And it could be narrowing of, arteries, or a clot would be also a way to cause ischemia, right? Something can be causing a blockage of blood flow. Um, Something also I've noticed that helps me when it comes to her exams is when she gives a very specific answer to very specific questions like these, they usually tend to be a part of the answer choice. So I would look out for that, right? Like if you see something that says stroke or ischemic stroke or something like that in the question, I would go for that, unless anybody else has anything they want to add for this.
No, you said everything. She just said also this is why people were dying because they weren't given anticoagulants, but you basically said everything.
Okay. All right. Yeah. So, just think of that, right? Like if I'm thinking COVID-19, I have to think, okay, stroke, right? Because there's clotting. Okay. So then the next question is identify clinical manifestations of a stroke. It says assess cranial nerves 1 to 9. I know like the first one's like olfactory, and then pretty much the rest of them between 1 and 9 are like eye related nerves. Then you have like your facial nerve in there. Um, and your auditory nerve. So those are some other things that you want to look for. So that's one of the reasons why when you have a stroke, right? Um, if they're having visual disturbances, potentially one of those cranial nerves, which are like 2, 3, 4, 6. Um, all of them are for the eyes. But anyway, I actually was looking up and there's this little mnemonic called FASTER, which I think would help if you want something to help remember the signs and symptoms of stroke. So the F is for facial drooping, the A is for arm weakness, the S is for speech difficulties, the T was for like visual disturbances, but I forgot what the specific word they used, but I just wrote it as eye problems. And then the E was for eye problems, the T was for time, and the R was for react. So reacting meaning calling 911. So if you know like facial drooping, one-sided weakness, speech difficulties, eye problems, you should be thinking, okay, stroke, right? And the thing with stroke is that because we don't know what type and the manifestations could overlap, such as between hemorrhagic and ischemic, one of your first things that you do want to do is if you're suspecting a stroke is to have a CT scan. And that's because if you want to give TPA, right, which is basically a thrombolytic to help break down clots, if they have a hemorrhagic stroke, they cannot get a TPA. So you need to do a CAT scan first to determine is it an ischemic stroke or is it a hemorrhagic stroke? Because if you don't know that, you're not going to be able to have the appropriate interventions. So you want to think about those things, right? Also, arm weakness or weakness on one side of the body could also be called hemiparesis. So if you see that term, don't be like, I don't know what that is, or I'm not really sure. Like hemiparesis also means one-sided weakness. So it's just another fancier way to see it, which basically just means the same thing. Um, Another thing is that because of a stroke, because they could have one-sided weakness, right, on one side, let's just say of the face, right, their tongue could just remain midline and they could occlude airway. So airway has to be one of the things that we look at. Another point that she said is that right-sided stroke is going to affect the left side and the left side is going to affect the right. And that's because of, I can't think of the name, but it's called corpus something. It's like this thing in the brain that basically transmits one side to the other. I can't think of the name. I don't know if anybody knows exactly what I'm talking about. It's called the corpus. It's called the corpus callosum. So basically, it connects both hemispheres of the brain, right? So the right side affects the left side of the body. So when they have a stroke, a right-sided stroke, the left side is going to be weak, right? Whereas a right hemisphere stroke is going to affect the left side of the body. So they're going to have left-sided weakness, and that's because of this corpus callosum, which is basically connects the two hemispheres of the brain so that one side can control the other. When that corpus callosum isn't working anymore, actually that's when the right side actually helps the right side and the left side helps the left side. That's just extra information. Okay. Anything else anybody wants to add for this question?
No, you could continue.
Okay. So the next question is to assess and provide clinical manifestations for a patient with ischemic stroke. So once again, ischemic stroke means that there's some sort of disruption to the blood flow caused by some sort of obstruction, like for example, a clot, right? So that's why we said for COVID-19, they're at risk for ischemic strokes because of abnormal clotting. We talked about, right, we give TPA for ischemic stroke. For these type of patients, they're going to present with the main presenting symptoms are hemiparesis or one-sided weakness, dysarthria, which is difficulty forming words, and they're also going to have visual disturbances as well as slurred speech. Okay, so those are the type of things that you look for, especially for ischemic stroke. Other things to always, consider is that our goal is to we prevent this the best that we can. So if we're talking about like primary prevention, we're talking about lifestyle modifications, especially telling them like not to smoke, make sure they're physically active, having a healthy lifestyle, because people who are at risk for ischemic stroke are people who have poor lifestyle habits. That's one of the contributing factors, like too much alcohol, too much smoking, so they can reduce their risk for having stroke. Um, I just wanted to point that out there. So like we see all these things like diabetes, excessive alcohol consumption, smoking, a sedentary lifestyle, hypertension, things that can be controlled by lifestyle modifications could be a cause of ischemic stroke. Um, Now, we have different management. The ones that I want to point out is obviously we're thinking about anticoagulant and antiplatelet therapies, especially if it's due to a clot that's causing the ischemic stroke. But TPAs are the primary choice, and we have to give them within 4 hours of the stroke onset of symptoms. Otherwise, it's not going to be as effective. And it's a temporary solution, but it does a lot when it's given in the right time frame. But we cannot give this to hypertensive patients because it increases the risk of bleeding. So TPA is contraindicated in hemorrhagic stroke, but it's also contraindicated with patients who have hypertension. So for example, if this is an ischemic stroke patient who has a really high blood pressure of like 190 over 120, they are not going to be getting a TPA. Another thing is that we want to prevent further neurological damage with these patients because they could be at risk for hemorrhage, so we need to really monitor that closely. And think about it, if we're having a stroke and they're recovering from a stroke, we see this patient, we want to do vital signs, neurological assessments, especially like that Glasgow Coma scale, right? We want to improve mobility. We want to move them every 2 hours, making sure that we could ambulate them when it's appropriate. Make sure we have a swallow and gag reflex with a puree diet because remember, they have weakness on one side, especially they could have difficulty chewing and things. So we want to make sure before we give them anything orally that we have a gag test and a swallow test. We want to check their nutritional status. We want to make sure that we sit them upright, right? They do the chin tuck method, things like that. We also want to make sure that we improve communication. They might have trouble communicating, so maybe we use a communication board or pictures or things that could be written. They could have sexual dysfunction, and we want to monitor their bladder and bowel function, right? Because that could be another thing that can be affected. So we want to look at all of those things. Another thing is I have this little chart. It's also in the textbook. It's table 62-1. And basically, it just talks about the main presenting symptoms, which I already mentioned for ischemic. It's more like the numbness on one side of the face, arm or leg. They have aphasia and vision loss. That could also be called homonymous heminopesia. I'm going to say it like that, which is another way of just saying like vision loss on one side. And for hemorrhagic stroke, we're talking about more of their symptoms will be like this really, really bad headache, worst headache of their life. They're going to have a decreased level of consciousness and anesthesia. Those are their main presenting symptoms if they have a hemorrhagic stroke. Okay, so the next question is to define common deficits when a client exhibits a stroke and focus on the site of stroke. So we already talked about, right, the right side. If they have a right hemisphere stroke, it's going to affect the left side of the body. And when they have a left-sided stroke, right, a left hemispheric stroke, I should say, they're going to have right-sided symptoms, like the right side of their body. So, things that I want to point out is that this is table 62-3 is a comparison of both. I find it useful. I love charts. But the left hemispheric stroke, remember, we're thinking about right side of the body when we have a left hemispheric stroke, they're going to have paralysis or weakness on the right side. They're going to have a right visual deficit, which means we're going to want to approach them from the side where they can see, right? We never want to approach them on the side where they can't see. They're going to have aphasia where they're going to have difficulty speaking. Specifically, they have receptive aphasia. That means they won't really understand what we're saying. They'll have altered intellectual ability and they'll have slow, cautious behavior. Whereas a right hemispheric stroke affects the left side of the body, right? So they're going to have paralysis or weakness on the left side. They're going to have a left field visual deficit. They're going to have spatial perceptual defects. So it's going to be like kind of hard with their balance and things like that. They're going to have they're going to be really distractible, very easily like distracted by things in their surroundings, and they're also going to have very impulsive behavior and poor judgment. So that's a difference in terms of presenting symptoms for if they have a left hemispheric stroke versus a right hemispheric stroke. And yeah, anything anybody wants to add or any questions so far?
No,
Okay.
we'll continue.
So the next one is to implement priority nursing intervention for a client with ischemic stroke. Focus on client vital signs as well. This might be a selector that apply. It seems like one of her NGN questions just based on the way it's worded. But remember, an ischemic stroke or any type of stroke, right? our priority is always going to be oxygenation, especially breathing patterns, because they could have one-sided weakness, right? They could have potentially aspiration because we said the tongue can go midline. So we want to have oxygen as our priority, as well as monitoring blood sugar because Dr. Remy was saying that hypoglycemia and stroke could mimic each other. So we want to be careful of that. Um, and yeah, anything anybody else wants to add?
So she just wants us to know for this one just to give oxygen and just monitor blood glucose, right?
Yeah, and like we did speak about other things. So if this is a select what apply, right, we could think, okay, like monitor blood sugar, right, oxygen. We also should be careful with nutritional status and making sure we do like a gag reflex, right? Like checking their neurological status, looking at vital signs, because if they're getting a TPA, right, they could be at risk for hemorrhage. So we want to check vital signs closely, like things like that. But if it were a singular choice, the priority has to be something with respiratory. It has to be something with oxygenation because the oxygen is going to help relieve the ischemia and help with alleviating those symptoms. So those are some things that we want to think about. Um, Anything else?
It's good, thank you.
Okay. The next is to identify clinical manifestations of a hemorrhagic stroke. So once again, we said worst headache of their lives, right? They have a decreased level of consciousness, right? They're at risk for seizures, things like that. Another thing that I want to add is I actually had a patient who said that they were just out drinking one day and they had a really bad headache, like nothing they've ever experienced before. And they went to the ER, something was just telling them to, and they actually had a hemorrhagic stroke. So severe headache is that one key indicator that's going to know that's a hemorrhagic stroke versus ischemic stroke. So just to like give like a real life example. And remember, these patients are also, especially hemorrhagic stroke patients, could be at risk for increased intracranial pressure. So we want to also monitor for that too. That's why neurological status is very important for both types of stroke, ischemic and hemorrhagic. But remember, hemorrhagic means bleeding, some sort of bleeding into the brain tissue, which means TPAs are contraindicated, right? But because there's blood bleeding into that brain tissue, right? Going into the spaces in the brain where they're not supposed to be, there's increase in intracranial pressure. So we need to watch out for that. That's why the manifestations include a sudden and changes in loss of consciousness, vomiting, even seizures, and a severe headache. And we know, right, for increased intracranial pressure, one of the earliest signs is an alteration in level of consciousness. So if we know that, we're like, this all makes sense, right? So diagnosis, once again, we need a CT. That's our priority to do when we suspect someone has a stroke because we cannot give someone who has a hemorrhagic stroke a TPA. For both, oxygen is always priority. We want to also, especially for these patients, keep them at bed rest because remember, if they have a risk for increased intracranial pressure, um, we have to worry about not moving them too much and keep them in a low stimulating environment. And they'll also, if we notice it's a hemorrhagic stroke, they'll also do a lumbar puncture and things to determine if they have increased intracranial pressure. But remember, the goal is to prevent the further of the bleeding, having no seizures, and if they have increased intracranial pressure, take care of that, right? So, of course, neurological assessment, things like Glasgow Coma Scale, Perla is going to tell us a lot, right? We'll see like loss of consciousness, maybe a sluggish pupillary reaction, which would be a response to increased intracranial pressure, cranial nerve deficits, speech difficulties, visual disturbances. Once again, they'll still present with signs and symptoms of stroke with terms of they might not see from one side, things like that, headache, and other things. So once again, different interventions can include optimizing cerebral perfusion, making sure there's aneurysm precautions, non-stimulating environment. That's really important for them because that would increase intracranial pressure. Keep the head of the bed at 30 degrees. You cannot move it. That they have to stay midline. You really can't move these patients too much. You really want to avoid any activity that's going to increase intracranial pressure or blood pressure. So that's why you have to keep their head midline. A stool softener if they're really constipated, a non-stimulating environment. We want to relieve anxiety because anxiety could also put pressure on them and reduce blood flow. We want to have seizure precautions. monitor for signs of rebleeding. So vital signs are going to be really important and things like that. Okay. The next question is to identify appropriate nursing management when communicating with a client with aphasia. So aphasia means that they can't really speak, right? So we're going to provide them with a board to write on. We want to talk really slowly with them and pause between phases and even use gestures, right? This could be simply like a one-worded response, like a singular choice. It could be a select all. But think, right? Like if this patient is having trouble communicating, right? We don't need to speak loudly to them or like try to really accentuate the words because they could still hear, they just can't speak back to us. So we're going to talk slowly with them, right? Pause so that maybe they take some time to think about it, right? They also might take a little bit more time with formulating responses because they might have to write it out. So things like that. Okay. The next question is to identify predictors of stroke and to help set a realistic goal. Now, Dr. Remy said what we want to do is assess the level of consciousness from time of admission, right? Consider their age, right? And also follow up with the National Institute of Stroke and Health. That's all I have for this question. But as I said, when I notice that when she gives specific responses like these, they tend to be the answer choices or a part of the answer choices in a question. So yeah. Um, Okay, the next question is to develop a nursing diagnosis for a client with cerebral contusion and cerebral spinal injury. Now, what I've learned from this, because I couldn't find much of it from the textbook at least, is that when somebody has a cerebral contusion or a cerebral spinal cord injury, they have a lot of loss of consciousness, right? And they have balance problems. So as a result of that, the nursing diagnosis or the priority nursing diagnosis is going to be risk for falls / injury related to neurological deficit because they have a change in level of consciousness. So if they're trying to get out of bed or something, they're more at risk for falls and hurting themselves. The next question is to provide nursing management for patients with brain injury and neurological trauma. Now, two things Dr. Remy mentioned was log rolling them to move them, and that makes sense because if they have a brain injury or neurological trauma, there's always also that risk for increased intracranial pressure, and also it's just the idea if there's something in the brain, right, and they have some sort of injury, you don't want to move them too much. So we want to use the log roll technique and keep them at 30 degrees. Now, just like any sort of brain injury, right, anything that's related to cerebrovascular, our priority always becomes adequate airway, right? We also want to keep, like I said, the head of the bed 30 degrees because we want to decrease any sort of pressure that goes into the brain, right? And if another thing that I want to point out is why airway is one of the most important things. Besides, right, you need your airway to breathe. You can die in a couple of minutes if you don't have an adequate airway. But the brain is specifically really sensitive to hypoxia or low levels of oxygen, so that can make the neurological deficits a lot worse. We want to limit suctioning only as needed because if they have increased intracranial pressure as a result, so we don't want them to cough or strain too much. We want to prevent against aspiration, look at the arterial blood gases, make sure they have good mechanical ventilation. And remember, if they're on a ventilator, we want to make sure that we assess for any sorts of complications, right? Like aspiration, pneumonia, things like that. Still brain related, so neurological functions like level of consciousness, especially that Glasgow Coma scale, that's the best indicator to know how is their neurological status, right? If the numbers are decreasing, that's showing deterioration. Vital signs, right? Because vital signs could show us a lot, especially if they have increased intracranial pressure. And if it's worsening, they could show Cushing's triad, which is bradycardia, hypertension with a widening pulse pressure, and even bradypnea or a slowed respiratory rate. And we also want to monitor the temperature because temperature, if it starts to increase, that could mean that, there's some sort of infection. That could also mean that there's a lack of control in the brain because like the hypothalamus monitors the temperature. So we really need to watch out for that, right? Good cardiac monitoring, Perla, things like that. Always, we want to monitor our fluid and electrolytes, make sure that they have good, adequate nutrition. If they can't take anything orally or enterally, we will do a TPN. And we want to prevent injury, right, for these patients. So we want to make sure that they could be at risk for seizure precautions or they could be at risk for self-injury. So, padded side rails, things like that. Don't use opioids just for restlessness. That's not something that we do. You want to reduce stimuli, making sure that they have good enough lighting so you could see things, but not enough to be too stimulating for the patient. And we want to minimize disrupting them when they're sleeping and things like that, um, because we want them to sleep and we don't want to increase their body stress. And another thing is that we want to maintain skin integrity, right? This could be a patient, especially if they have a severe brain injury, if they're comatose, they might not be getting out of bed. So we want to turn and reposition them frequently and provide um, skincare like every 4 hours and turn and reposition them every 2 hours and things like that. Okay. The next question is assess cardinal signs for a client who's brain deaf. Now, the three main signs that I would just say you just need to know is that brain death is determined when they're in a comatose state, they have absence of brainstem reflexes, and they have apnea, where they don't breathe on their own. Those are the three things that I would know. I don't think you need to know anything else. The last thing is to identify clinical manifestations of elevated increased intracranial pressure and provide nursing management. Now, Dr. Remy mentioned things like the widened pulse pressure, the bounding pulse, irregular breathing, things related to the Cushing's triad, as well as mannitol, right? Because mannitol is an osmotic diuretic that's going to remove fluid from that cerebral space. But right, increased intracranial pressure. We already talked about level of consciousness being changes in LOC is going to be one of the earliest indicators, right? Which is also an indicator in hemorrhagic stroke. So that's why we know with those two, they can be closely related. Other changes that are early signs are different pupil sizes, um, and impaired eye movement. So perla is going to be a really good thing that we need to assess with them, right? They could have weakness in one side of the body and a constant headache. Those are our early signs. Late signs are going to include Cushing's triad, projectile vomiting, and if it gets really, really bad, they'll have these positionings, decorticate and decerebrate. So if we see in the question, they're talking about decorticate and decerebrate posturing, we're thinking late signs of increased intracranial pressure, and it could lead to brain death. So just like we're doing everything else, right? Like the priority is always going to be respiratory status, right? Having a good patent airway, keeping the head neutral, right? Don't moving the head more than like 30 degrees. Um, no hip flexion, have a calm, quiet environment and protect the patient from stress. You want to monitor fluid status carefully every hour, especially because they're probably getting lots of fluid. We want to have a strict sterile technique when we're monitoring increased intracranial pressure, especially if there's very invasive things, because once again, their brain stem and their brain abilities could be very much altered. And as a result, they might not be able to respond as well to, changes in temperature and immune status. So we really want to be very, very careful. Any questions about anything that I spoke about?
I had a quick question. When you said the cardinal signs, it was comatose, apnea, and what else?
Absence of brainstem reflexes.
Absence. Okay, thank you.
Yeah, I feel like it could be like a select all that apply, as she said, list of three cardinal signs, unless it's written out in like a singular one. Just know those three. Those are the three signs that you know. Anything else would not be relevant. It would just be those three. If it says coma, absence of brainstem reflexes and apnea, brain death. It's all you need to know, or at least all I think you need to know. Um, okay. Um, So the next chapter is renal. Sorry, it looks really weird because I have to scroll up instead of scrolling down. So takes me a little extra. But if there's no other questions, I'm going to start with chapter 48, which is renal and kidney. So the first question is to list laboratory values that reflect a decreasing glomerular filtration. Now, decreasing glomerular filtration makes me think, uh-oh, there's something wrong with the kidneys, right? So anytime there's something wrong with the kidneys or there's some sort of kidney injury, creatinine and BUN is always going to be increased. That's going to let you know there's something wrong with my kidneys because they should not be increased otherwise. Another thing that Dr. Remy specifically mentioned was creatinine clearance. So if it's less than 75, that means kidney disease. That's what she specifically mentioned. And just for lab value reference, creatinine is like 0.7 to 1.4. I think that's for males. And I think for females, it's like 0.6 to 1.2. It's around there, right? But if you see a number like 2, definitely really high, right? And BUN is around 8 to 20. So if you see like 25, we're thinking, okay, there's something going on with the kidneys, right? And just because I had this, I added it into my notes about the different renal tests, and she mentioned the 24-hour creatinine clearance. And that's one way that we measure kidney function. So what you do is it's a urine test, because think about it, kidneys, the best way to know if your kidneys are functioning is urination, right? Because if they're not really urinating, that's a sign of kidney injury. So you're going to discard your first urination and take that patient's second one, and it's going to be done over a 24-hour day to see the fluctuation because creatinine can fluctuate during the day, but we're going to see is it normally high in a 24-hour period or is it not? Another thing is that creatinine generally is the most effective measurement for renal function. So you really want to look at that very closely. BUN is also an index of renal function, and the BUN to creatinine ratio should be between 10 to 1 and 20 to 1. If it's higher than that, we're thinking kidney problems. Last thing, urine-specific gravity, right? We said they're not going to really be peeing as much when they have kidney problems. So the urine-specific gravity is going to be higher because the urine's going to be more concentrated when it comes out. So it'll be greater than like 1.030. Okay. Anything anybody wants to add? Okay. So the next thing is to assess clinical manifestations of a client with kidney injury secondary to renal calculi. Now, some things that Dr. Remy was saying was assess and monitor the client's condition for oliguria. So oliguria we know is urine output of less than 30 milliliters per hour and fluid volume excess. So we know that we're going to have an indwelling catheter so that we could see their output. We're going to measure INOs and daily weights. That's going to be so important, especially for our kidney patients, because it's the intake and output that lets us know, are their kidneys doing good or not so good? Another thing is that renal calculi can lead to acute kidney injury. Now, I did add extra notes because sometimes I like to have a little bit more. It helps me understand things more. But an acute kidney injury, right? It's a rapid loss of kidney function. So there's a lot of damage to the kidneys. So we get that decreased glomerular filtration rate, which is what we were talking about before in oliguria. So a sharp decrease in urine output would indicate, something just happened to the kidneys. Now, interestingly, there's 3 categories of acute kidney injury. There's pre-renal, intrarenal, and post-renal. I'm not going to get into everything, but pre-renal just means decreased blood flow. So anything that can decrease blood flow can cause acute kidney injury. Intrarenal usually means damage to kidneys. So there's an increased BUN and increased creatinine. Okay. We saw that. And for post-renal, it's obstruction to urine flow. And kidney stones are a post-renal complication that can cause acute kidney injury, which is blocking urine outflow. I just wanted to point that out. There's different phases. So if you're wondering why they can become in fluid volume excess, it's because that first phase of oliguria, or one of the beginning phases, initiation, but oliguria as being one of the main ones, right, lasts 1 to 3 weeks, but it has that sudden decrease in urine output. And as a result, they become edematous and they start filling up with fluid. And they also have an elevated BUN and creatinine and potassium, and they can go into metabolic acidosis, which is why we want to monitor for fluid volume excess. Like I said, I don't need to get into everything. This is pretty much all extra, other than just knowing that potassium is one of the electrolyte imbalances that can come from acute kidney injury, especially if it's renal calculi. If that's the cause, regardless. So we really got to watch out for fluid and electrolytes, especially our potassium levels. And for that oliguric phase, right, or any sort of kidney injury, we want to make sure that they have a low protein diet. and a high carbohydrate diet and make sure we restrict potassium. I just wanted to point that out for you because I feel like it could come up like if you see something with diet, you have to think with kidneys, you want to have a lower protein level. You don't want a high one. Another thing is they can go into another phase, which is diuresis. So if the acute kidney injury gets better, right? Because it's acute, right? It's temporary. They can go into a period of diuresis where they start peeing again, and then things start to normalize a bit. That's where we might want to restrict fluids, but the same thing applies where it's low protein. I know this is probably extra, but I just kind of wanted to give you this the sum up of why we're kind of doing all these things. Like, right, why are we monitoring vital signs? Why are we looking for fluid volume excess? How does the renal calculi cause the acute kidney injury? I don't know. I always find that helpful to kind of have the full picture. Um, okay. So, any questions? Okay. So the next question, unless if there's a question, just stop me anytime. You don't even have to wait until I say if you have any questions, by the way. Um, but the next question is to be familiar with an AV graft and an AV fistula for hemodialysis and assess complications. Now, the notes, all I had that Dr. Remy said was that AV graft and AV fistula are permanent, and perm cath, I probably wrote it wrong, is temporary for dialysis. And that is usually like a lumen catheter, could be two or a double lumen or a triple lumen catheter. Um, it's definitely not fun, the temporary dialysis catheter, because they remove it like every week and then they reinsert it as they need it to the patient. It's very, very painful. But if they have an AV fistula, an AV graft, there's a few things that we want to look out for. But let's first talk about why we use hemodialysis. Well, it's typically used for someone who has like chronic kidney disease or they need some sort of replacements. Usually, could be long term, it could be acute. It really just depends on the situation, but it helps with removing toxins, excess water, and substance from the blood, right? And one of the things that we want to look out for is when we have a patient who's on hemodialysis, the reason that they have an arterious fistula and an arteriovenous graft, or called AV, it's a vascular access that allows these patients to get their dialysis, right? So we want to look for thrills and bruits. So a thrill is something you could palpate. It's related to turbulence of blood flow. You could palpate it, you could feel it, and a bruit is something that you can only hear when you auscultate. So for a fistula and a graft, really, really important things is that they should have a limb alert bracelet. They should have something on there to let you know, hey, do not touch this arm, right? Or a sign in the room. Even if they don't have that, one thing is that there's no blood pressure given on the side of the arm that has an AV fistula and a graft. So if they have a right-sided fistula, you got to take the blood pressure on the left side. You cannot draw blood from the fistula or the graft from the same arm. So if you need to draw blood, you don't go on the right side, you have to go on the left side if it's on the right. Those are some things that I want you to think about because it could burst. Essentially, you could put too much pressure onto that fistula, onto that graft, and it will basically break. So those are some really important points. Okay, the next question is to be familiar with peritoneal dialysis and indicate potential complications. So Dr. Remy said that we want to assess for infection at the site of the abdomen because peritoneal means abdomen. This is dialysis that's given through the stomach. Potential complications can include pulmonary edema and peritonitis, which we're going to see a cloudy dialysate, which is the fluid that goes through them when they're getting the dialysis. So if it looks cloudy coming out, that's not normal. It should be clear. She also mentioned nephrotic syndrome. I don't think we need to know that as it's not really a complication of it, but nephrotic syndrome is usually like generalized edema, hematuria, hyperlipidemia, and proteinuria. But that's just for you. She mentioned it, so that's why I'm mentioning, but I don't think it's like super related to this. But like I said, peritoneal dialysis has the same goal as hemodialysis in the sense that it's removing substances, right? But this is for someone who can't tolerate hemodialysis, who doesn't want to tolerate hemodialysis, they don't want that option, and they can't get a kidney transplant. So they'll get peritoneal dialysis. They do this at home, right? They don't need to use any sort of like sterile technique. It's something that they do every day of their lives. So they know how to do this very well. But the complications could include peritonitis, which we know can cause a rigid, board-like abdomen. They're at risk for infection, leakage, loss of protein. So for these specific patients, we want to increase protein. Even though we said, right, with acute kidney injury, low protein, because peritoneal dialysis can cause too much of a loss of protein, they need to increase protein in their diet, as well as they have a risk for bleeding and hyperglycemia. So, once again, is that if they're ill, we want to tell them that they should wear a mask when performing exchanges. We should wear one, and they should wear one, especially if they're sick, because that could contaminate the catheter. And cloudy dialysate, like I said, can be an indicator of peritonitis. And for diet, it's going to be increasing protein and have a high calorie diet. Okay. Any questions?
Going good. Thank you.
Okay. So the next thing is to assess and monitor a client who has an indwelling catheter after they've had it removed. What nursing management is necessary? So a few things is that one of our priority things is urination. Right? We want to make sure that they go to the bathroom after it's been removed. They're able to urinate at some point. And if they only are showing a little bit of urine output, right? Like just a little bit, they've had it out for a few hours, nothing. We want to do a bladder scan first. We want to make sure that they even have anything in their bladder. To determine, what our next steps can be. Another thing I've noticed is looking over practice questions is that this is like a clean technique, right? These patients, if they also have actually wait, I'm thinking about something else. If they're a patient, let's just say they go through this, they have it removed, they do a bladder scan, right, and it shows it's still there. Maybe they go home with some sort of catheter where they do it themselves. It's always going to be a clean technique, and we'll get more into that later. I just wanted to mention that. But like I said, we just remove the catheter, our priority is urination. And also if they haven't urinated, let's just say six hours after they haven't urinated, the first thing, our priority intervention is going to be doing a bladder scan. It's the least invasive thing that's going to let us know what's going on in the bladder. If they have nothing, right? All right, then that's why they haven't peed. Or it could be signs of something else, right? So all things to consider. The next question is to implement appropriate clinical intervention for a client with urethral strictures. Now, I couldn't find much about what this is. So if anybody knows what this specifically is, you are free to share. The only thing I found out about it is that it obstructs urinary flow. And Dr. Remy said if somebody has this, we instruct them to use a warm sitz bath. Anybody have anything else to add?
Yeah, that's all she said. I just found in the textbook that it's a section of the urethra that's narrow due to scarring or injury. So they're not able to like pee. So they have urinary retention and sits back. That's all.
Okay, thank you. I don't know why I could not find anything. So I was like, all I saw that it said it obstructs urinary flow, but thank you for that. Now we know what it is. Okay, yeah. So warm sitz bath is the intervention. And as someone said, right, causes urinary retention. Okay. The next thing is to provide education for a client who has a calcium oxalate renal calculi. Now, we already know that a renal calculi can lead to acute kidney injury. We know that we want, for these patients, we want to increase fluid intake, and we also want to restrict protein and sodium. Now, the reason that we want to increase fluid is that it actually really does help with slowing the tendency to form stones. So if they drink enough fluid, that really helps. And they should be drinking about 3 liters a day. They should limit sodium intake to 3 to 4 grams, and that's because high salt foods, really high things, actually competes with calcium absorption. So in other words, if sodium is really high, calcium is not going to be able to decrease in the body because they're fighting to be reabsorbed. And as a result, the stones or the problem with stones isn't going to go away. They need to avoid intake of oxalate containing foods. That's like spinach, Swiss chard, chocolate, peanuts, and pecans. They should also recommend to drink 2 glasses of water at bedtime and an additional glass each at nighttime, awakening to prevent urine from becoming too concentrated during the night. They need to avoid any sort of activities that are going to lead to increases in temperatures, such as like really excessive sweating and dehydration. And we want to also make sure that we contact the provider if we see any signs of a urinary infection, such as maybe a temperature or a burning on urination. We want to report that. And this came from a chart in the textbook on page 1622. Okay. The next thing is to provide education of a client with intermittent self-catheterization, indicate the client's feedback for effective education. Now, one, these patients are going to be incontinent, and that's the reason why they're getting it, right? I know she said aseptic technique, but the textbook said clean technique, and that's because they're going to continually reuse these catheters at home. They're going to do this for every 4 to 6 hours, and they need to lubricate the catheter before. So we're not using a sterile technique, we're using a clean technique. And if you want to check, it comes from page 1620 in the textbook. We use an antibacterial liquid soap to clean the urinary catheters at home. You rinse it with the warm tap water and must be dried before reuse. And it needs to be kept in its original container, such as if it came in, or if you have like if you put it in a plastic food storage bag or something like that, it needs to stay wherever it came in. Another thing is, like I said, every 4 to 6 hours, and we want to make sure that you lubricate it and that they use a clean, not a sterile technique. Okay, I just want to put that out there. I know she said aseptic, but it's non-sterile because they're gonna be reusing this. The only time they begin to discard this is if something damages that catheter. Otherwise, they're just gonna be continually reusing it. Any questions? Okay, so the next chapter is chapter 46 on diabetes mellitus. There's 5 questions. I do notice she has more questions in here than the number she put at the top, but it's okay. We're still going to go through everything. So the first question is provide patient education regarding self-management of insulin regimen. Now, what she specifically noted was that a vial of insulin is good for 1 month. At room temperature as long as they're using it, and it should be dated and initial, especially if we're using it in the hospital. But if they're using it at home, right, they can leave it out for 1 month at room temperature, and when it gets greater than 1 month, then they have to put it in the fridge. But if they're using it every day consistently, it can be left out at room temperature for 1 month. I would know that. The next question is to assess a client with a history of type 2 diabetes and identify the causative factors. So, Dr. Remy was mentioning things like obesity, high blood pressure, low HDL and high LDL, and a high blood sugar reading from a hemoglobin A1C. Now, the thing that I want to mention with this is type 2 diabetes, right? It's one of the more common types of diabetes, and that's because it's due to lifestyle, right? So, like we said, obesity, high blood pressure. Even if they had a history of gestational diabetes, that increases your risk for type 2 diabetes, as well as if you had a really big baby, like over 9 pounds. If you're obese, and typically we see this in patients who are greater than the age of 30, and it's due to this carbohydrate intolerance, and they have an insulin resistance, whereas type 1 is more of an autoimmune, right? And it's due to no or very, very, very little insulin production. And that's why type 2 diabetes is called um, non-dependent diabetes mellitus because they don't need insulin. But type 1 is insulin dependent diabetes mellitus because they need to take their insulin every day, right? Type 2 could take oral glycemic agents. They don't need insulin every day because they still produce it, just not in the most effective way. Whereas type 1, they don't really. So if they don't get their insulin, their sugars are going to go unbelievably high with no sort of control. But yeah, once again, type 2, think lifestyle, so obesity, low HDL, high triglycerides, high LDLs, right? Hypertension, maybe a history of gestational diabetes, a bigger baby, and greater than the age of 30. So the next question that goes along with type 2 diabetes is what are the clinical manifestations? So we talked about what this is, right? We know that for these patients, they're not going to be at risk for diabetic ketoacidosis because they're not going to form ketones in urine. That's a type 1 complication. Type 2 would be hyperosmolar syndrome, that one. So, like we said, the management typically for these are going to be oral hypoglycemic agents. The clinical manifestations are our 3Ps. Now, does anybody know what the 3Ps are?
Yeah.
Polyuria, polydipsia, polyphagia.
Exactly. Those are the main presenting symptoms, right? Polyuria, they're peeing too much. Polydipsia, they're very thirsty. Polyphagia, they're very hungry. Also other things can include, right, like any diabetic patient, visual changes like or retinopathy, tingling and numbing in the hands and feet, or peripheral neuropathy. They could have wounds that are slow to heal, right? That's typical of both, right? The 3Ps is also typical to both type 1 and type 2. Really, the only difference is that for type 1, they could also experience weight loss in addition to nausea and vomiting, but everything else is the same. Also, diabetic patients are at risk for infection. So those are other things, but the 3Ps are one of the main ones, right? Okay. So, and that's because it's caused by hyperglycemia, right? So even if it said, oh, like they don't have to specifically say what are the manifestations of diabetes mellitus, they could just say the patient is having manifestations of hyperglycemia, and you could also think your 3Ps, right? As well as like fatigue and things like that. Okay. The next question is to identify clinical management for a client with diabetic ketoacidosis and focus on insulin administration. So we know that diabetic ketoacidosis is a problem of type 1 diabetes, right? It's specifically a metabolic derangement that occurs mostly in patients who have type 1 diabetes, and it results from a deficiency of insulin, and it causes highly acidic ketones in the body to form and metabolic acidosis. The three major problems that we see with diabetic ketoacidosis are dehydration, electrolyte imbalances, and acidosis. So those are our main problems with this. But because DKA is due to a rapid increase in blood sugar, right? We have that polyuria, that polydipsia, the polyphagia. It's very abrupt onset. And as a result, they even have things like a fruity acetone breath, ketones in the urine, and Kussmaul's respirations. This can greatly affect the kidney. So they have elevated BUN and creatinine, which we said elevated means problems with the kidneys. And management priority is going to be rehydration with IV fluids. And we're also going to give as the insulin of choice regular insulin. And that's because it's the only IV insulin and it's very short acting. Other things we're going to want to monitor those electrolytes, right? And a good CBC and things like that, as well as making sure we check those BUN and creatinine levels, have blood sugar monitoring. They should be NPO because they're also at risk for nausea and vomiting. They need frequent blood work. We want to get a urinalysis, especially looking for ketones, and we want to monitor renal function, right? Because of that BUN and creatinine. And the best way to do that is looking at our INOs. And we said another major problem, right? We said dehydration, electrolytes, and acidosis. So we want to check, right, our ABGs, and we want to make sure that we correct any sort of electrolyte imbalances as a result. So I just have this like little chart that kind of goes over the different types of insulin. I'm not going to really get too much into it, but with rapid acting like Lispro, asparglucine works very quickly, so they need to have food there immediately when they get it. I see a hand raised.
Yes, I had a quick question about the DKA. Would you want to treat the dehydration first or the insulin?
Hydration, always first. I've noticed when I come across questions, the answer always has to do with hydration first. And that's because they can become very, very dehydrated. And because of the really high sugar levels, you want to get them running with IV fluid first before we give them anything else. So yeah, priority, DK. If it's a singular choice, it has to be rehydration with IV fluids. We want to do the other things, but that's going to help with the fluid and electrolyte imbalances. That could help with the acidosis, right? That's going to help with that potential dehydration. So we want to get that in first. Okay. The next question is to identify clinical manifestations of a client with diabetes. We already basically talked about that, so I think this is just a repeat question, but just once again, right? That we know the 3 Ps, right? Retinopathy, delayed wound healing, neuropathy, nephropathy, so kidney problems, and we want them to have annual eye exams because remember they have retinopathy or visual problems, and they want to inspect their feet daily because the peripheral neuropathy or that nerve tingly feelings that they have, they could lose sensation, especially in their feet. So they might not feel when they have a cut or something goes into their foot. So they want to make sure they inspect their feet daily. Okay. The next question is to identify clinical complications of type 1 diabetes and provide rationale. We already went over most of this. DKA is that main complication. We know that type 1 diabetes is also insulin-dependent diabetes mellitus. So those insulin-producing beta cells are pretty much destroyed. It's an autoimmune problem, and they're not really producing any sort of insulin. It's very abrupt. And for these patients, as we said, it's autoimmune. So most of the risk factors for type 1 is genetic preposition, a familial history of it, and they'll typically have an earlier onset less than 30 years of age. We know that complications of diabetes already include hypoglycemia, especially if they're receiving insulin in this case. So we want to make sure that we watch out for like signs of sympathetic stimulations like headache and palpitations, tremors, tachycardia, nervousness, diaphoresis, right? Confusion, things like that. The hypoglycemic effects are very stimulatory, whereas hyperglycemia is more calming, right? Like they're more fatigued. We already talked about DKA and our priority. Remember, IV fluids, priority, DKA, and hyperglycemic osmolar syndrome is for type 2. Like I said, very similar to the other one. It just doesn't have ketones in the urine. Lastly, right, there's that macrovascular, which includes cardiovascular problems and cerebrovascular disease, so like stroke, right? Microvascular includes retinopathy and nephropathy, and neuropathic problems would be, like we said, that parasynesthesia, tingling in their feet and their hands. Okay, the next question is to emphasize causative factors of hypoglycemia, identify clinical manifestation, and provide clinical management for hypoglycemia. So regardless if you're type 1, type 2, as we said, could be the reason why they're getting it. Is it from the insulin or is it from the oral hypoglycemic agent? Something is causing the blood sugar to go less than 70. Now, this could be because they took their insulin and they didn't eat anything or didn't eat enough, or they took insulin, they exercised, didn't eat, they exercised, they didn't eat. Get the pattern, right? All of those are going to decrease the blood sugar. Now, we said manifestations are going to be like sympathetic stimulation, so shakiness, sweating, nervousness, hunger, things like that. In an emergency, we give a 15 gram of fast-acting concentrated carbohydrate. This is if the patient can swallow and they're alert. So this would be like a 4 to 6 ounce juice or regular soda. You could add 2 to 3 spoons of sugar or honey into it, or they can take 6 to 10 hard candies. And we want to retest the blood sugar every 15 minutes until the blood sugar is normal, right? Now, if they're unconscious, we will give them subcutaneous or intramuscular glucagon, or we'll give them 25 to 50 milliliters of 50% dextrose IV. Okay. Okay. Now the last, is this the last question? Yeah. The last question is provide the clinical manifestation of hyperglycemic hyperosmolar syndrome and provide clinical nursing management. Now, like I said, it's pretty much the exact same thing as DKA. The only difference is that there's no ketones. So they're going to have pretty much the same symptoms, polyuria, polydipsia, polyphagia, but they're not going to have the acetone or fruity breath or Kussmaul's respirations because that's a part of DKA. Now, these patients are going to have a decreased urine-specific gravity and a decreased urine osmolarity, just like DKA because polyuria, right? peeing too much, their urine's not very concentrated, right? We want to have adequate hydration. That's still going to be the priority. We're still going to give these patients regular insulin IV, have glucose monitoring. They could have electrolyte imbalances, so we want to do that. Pretty much same interventions, just the only difference is there's no ketones in DKA because DKA is a type 1 problem and hyperglycemic hyperosmolar syndrome is a type 2 complication. Any questions about anything we spoke about for this chapter? Okay, so chapter 40 to 41 is GI. So the first question is to provide clinical nursing management of a client with peptic ulcer disease and focus on medications. Now, I believe like for this question, the way it's worded, it's gonna either be, I think she's gonna repeat questions. That's just my feeling. Don't know. But even if it's not, there was a few similar things that she brought up, which was the idea of either the types of medications that you gave, such as, right, for peptic ulcer disease, we give a triple antibiotic therapy, PPIs, histamine 2 blockers, and bismuth salts. So I definitely think it's going to be either something related to that question that we had like on the quiz where it's like identifying what they do or even picking medications like the H2 blockers. I think it'll be something very similar to that. But regardless, right, we give the PPIs and the H2 blockers to reduce secretions, and the antibiotics are to kill and destroy bacteria. Okay, PPIs do not heal. They're not going to heal the lining. Healing of the stomach lining is actually going to be what the bismuth salt do. The PPIs do not do that. And the triple therapy of antibiotics will include amoxicillin, methronidazole, and clarithromycin. Those are going to be the 3 medications. Now, we know, once again, peptic ulcer disease is typically caused in duodenum, so we typically see manifestations of duodenal ulcers. They're at a really high risk for perforation and bleeding, and risk factors could include overuse of NSAIDs, H. pylori, which is one of the most common causes, corticosteroids, uncontrolled stress, smoking, caffeine, alcohol, diet, even type O blood. So we know, complications could include that gastric outlet obstruction, proliferation and penetration, upper GI bleed, and peritonitis. Manifestations depend on the type of ulcer because it could also be in the stomach, but it's mainly in the duodenum. So we know that our histamine blockers for medications are going to end in tadine, right? So famotidine, tadidine, nitizidine, and our PPIs are going to end in prazole, like omeprazole, lisinopril, omeprazole, pantoprazole, things like that. Okay. Next question is to identify complications of a post-gastroduodenoscopy. I'm going to say it like that. So Dr. Remy said we're worrying about dumping syndrome, right? And dumping syndrome is a physiological response where there's a rapid emptying of gastric contents into the small intestine. They'll get symptoms like palpitations and sweating and really dizzy, and it's relieved as soon as they have a bowel movement. And since they're at risk for this, right, when they're having gastrectomy, there's a few different interventions we want to do. One being small, frequent meals. They need to avoid simple sugars and have a low carbohydrate meal because they're also at risk for postprandial hypoglycemia, which I know we talked about this with like, why is it so weird? Well, the postprandial hypoglycemia increases, like they have an increased insulin output in a response to all that glucose that's coming into the small intestine. That's why we want them to eat low carbohydrate meals so that doesn't happen, so that insulin production isn't stimulated as highly. So we want to avoid simple sugars, eat a low carbohydrate diet, have fluid between meals, not with meals. If it says between, that's good. If it says with meals, no, only between meals. They should lie down for 30 minutes following a meal to help slow gastric emptying. And because everything's being like absorbed so quickly, like they're not even really having time to absorb anything because it's just going through the intestines just so quick that they're at risk for pernicious anemia or vitamin B12 deficiency. So you want to look out for that. Okay, the next question is management of patients with gastric and duodenal ulcers, right? So gastric ulcers, duodenal ulcers, they could both be caused by H. pylori and overuse of NSAIDs, right? All of that stuff. But for gastric ulcerations, the thing is, they have pain 1 to 2 hours after meals, and it's aggravated by eating. Does anybody know why? Well, it's because a gastric ulcer is an ulcer in the stomach. So if you're eating, right, and your food is going down your esophagus, it's going into your stomach as you're eating, it's hitting into that ulcer and it's going to make it more painful, right? That gastric acidity is going to increase, it's going to further hurt the ulceration. Whereas a duodenal ulcer has pain 2 to 4 hours after meals, and it's actually relieved by eating. And that's because, right, duodenum is in that small intestine, right? So when you're eating, that sphincter, or imagine it's like a door, the door between the stomach and the duodenum is closed. So when you're eating, you're not having that door open. So the duodenum's just chilling out there, like, okay, no problems here, nothing here. It's actually, I feel pretty good. Then 2 to 4 hours after eating, when that door opens to go through the small intestine to be absorbed, you get pain. You get pain because now it's open and now the chyme is irritating that ulcer. And for gastric ulcers, you'll typically see epigastric pain, whereas a duodenal ulcers, they're going to have mid-epigastric pain. Another thing is that we want to really focus on dietary for both of them. So avoiding NSAIDs and steroids and avoiding smoking, avoiding extreme temperatures in food, such as like really hot or really cold, no coffee or alcohol, milk or caffeinated beverages, right? Low fat diet. So like salads, lean meats, beans, things like peppermint too could be very irritating. They should sit upright after eating for of at least 30 degrees, and they should not eat right before going to bed. They should avoid, specifically 2 to 3 hours before bed, they shouldn't be eating anything and have small, frequent meals. Okay. The next question is to assess and identify clinical manifestations of a client with gastric ulcer experiencing perforation. When we talked about a gastric ulcer, right, that it's aggravated with food, pain 1 to 2 hours after eating, and they could have perforation. Now, perforation is basically it's more common with duodenal, but it could occur with gastric, and it's this sudden and severe upper abdominal pain that can radiate to the right shoulder, and it has a rigid board-like abdomen. Those, if there's any symptoms or anything that you know about perforation, know those three manifestations. Yes, they can go into shock and things, but I would know the sudden severe upper abdominal pain, as well as the other two symptoms I spoke about. Okay, the last question is to assess and monitor a client receiving TPN, indicate potential complications with a TPN infusion. Now, total parental nutrition is given through what? What do we give it through? What kind of line?
Central line, PICC line.
Yes, a central line or a PICC line. They're both central lines. So, any sort of central line, and you give it for a few different reasons, right? If they have impaired ability to adjust nutrients, um, if they have an insufficient, they're not getting enough nutrients through orally or enterally, they have an impaired ability orally or enterally, they don't want to take foods orally or enterally, or if they're waiting a really long time preoperatively and postoperatively, right? Especially like if they're having, another thing to point out, if they're having like an impaired ability for like a week, that's very concerning too. Now, the thing is that the admixture of the TPN has a lot of things, right? Like lipid emulsions, protein, carbohydrates, water, electrolytes, vitamins, minerals. It has everything, but it also has glucose. It has sugar. So one of the two major problems with a TPN is that one, it's a central line, and that it has sugar. Now, wherever sugar goes, bacteria goes. So you're at risk for hyperglycemia and you're at risk for infection. One being it's a central line, and two being wherever sugar goes, like I said, bacteria goes. They like each other. So as a result, they're at risk for infection. So another thing that we want to do for these patients is closely monitor blood sugar and monitor for signs and symptoms of infection. Other problems include pneumonia thorax, air embolism. The catheter can become dislodged or there's a clot. They could go into sepsis. They can have hyperglycemia, fluid volume overload, and even rebound hypoglycemia. I do believe that for this question, the one that might come back for this exam would be the one that was the select all that apply when it came to complications, because it just looks very similar to the one from the previous outline. So I would definitely focus on knowing the complications. Um, okay. Is there any questions about anything?
No, so far so good.
Okay. Sorry, it takes me a little while because I have to scroll backwards, which is a very weird experience for me. Um, okay. So the next chapters then are chapters 36 to 37, and it's defining the pathophysiology, risk factors, clinical manifestation, and finding procedure interpretation for a client with osteoporosis. Now, what all I heard Dr. Remy say for this was that osteoblast, the B, right, cannot keep up or building the bones at the same rate that bones are broken down by osteoclasts, because osteoclasts are the ones with the C, right, break down bones. But osteoblasts, the B, build up bones. So you could think for B for build and C for cut. So if that helps you, like, oh, it cuts bones, B builds bones. I don't know if you like little things like that. Sometimes that helps me. As well as being obese, having a BMI greater than 30. She specifically mentioned that. So maybe it'll be like a select all where it's like, what would be the risk and like, what does the nurse expect? And that this patient would have like a BMI greater than 30, things like that. But like I said, osteoporosis is this condition where the bones become brittle, and that's because, as we said, those osteoclasts are cutting the bones at a quicker rate or at a faster rate than the osteoblasts are building up bones, okay? So typically it's more common in women, especially women who are have the onset of menopause. Um, Other risk factors would include diet, exercise, a family history, previous fractures, use of corticosteroids, smoking, things like that. Another thing is that because the bones are becoming really, really brittle, they're at the most common risk factor is fracture. So we really want to monitor for that closely. Um, Other risks, like I said, women are more at risk, especially smaller framed women, women of ethnicities of Asian and Caucasian descent. If they have a bariatric surgery, right, if we're talking about that dumping syndrome, because there's also a problem with duodenum and there's a problem with absorption of calcium, and calcium is what helps build up bone. Another thing is that excess cortisol interferes with osteoblast formation. And remember, cortisol, is one of those things or one of those steroids, I say, that it's going to be increased, right, when somebody has something like Cushing syndrome, right? So Cushing syndrome has increase in steroids, has increase in cortisol, would also be at risk for osteoporosis. And hyperparathyroidism causes too much calcium in the blood. Now, too much is not that good, and as a result, that can also affect bone growth. But regardless, is that we want to have a balanced diet. Typically, these patients are going to have low calcium levels. So we want a diet high in calcium and high in vitamin D. That's going to help with bone growth, right? We want to use calcium supplements. So we think with osteoporosis, calcium and vitamin D. We want weight-bearing exercises for at least like 30 minutes a day. Lifestyle modification, especially if they're overweight, no carbonated beverages, no alcohol, no smoking, weight training, and make sure they avoid steroids if they can. And yeah, remember calcium, vitamin D, um, as well as weight-bearing exercise. Those are the main things that I see come up. Now, we also have bisphosphonates. Now, these increase bone mass and decrease bone loss. Now, does anybody know what we're supposed to do when we give someone bisphosphonates like alendronate? What we do? What's the nursing management for that? Like, do they take it with food or not with food?
Before food and sit for 30 minutes.
They should sit upright for 30 to 60 minutes. they should take it on an empty stomach with a full glass of water, okay? And the other thing, I forgot was saying, but this medication, the reason why we want them to sit upright, besides the fact that we want it to, go down, is because they can get something called like laryngeal edema. And they can have like laryngeal spasms. So we just want to make sure that we keep them sit upright for that reason as well. Like I said, other things can include, there's a whole bunch of other medications, even including statins. Calcitonin is another one, and that's because it inhibits the osteoclast and reduces bone loss. A good way to figure out like if they have osteoporosis would be a DEXA scan, which is a bone scan, no DEXA scan. But yeah, your main things for osteoporosis include, okay, bones are breaking down, bones aren't strong. They're at risk for fractures, risk for falls, so we need to have fall precautions, right? Calcium, vitamin D, biphosphonates, weight-bearing exercises, right? And reducing weight. So we're ready to the next question, which is knowing the pharmacological effect of alendronate and the nursing intervention. So I'm not going to go over that again. The next question is to identify the causative factors for amputation and list complications and provide patient teaching. So Dr. Remy specifically just said to know that phantom pain can affect the residual limb and the other limb. So the limb that's affected and the limb that's not affected. I added a bunch of extra stuff just in case, but we know that if someone is an amputation patient, right, and let's just say it's a recent one, right, our priority is going to be a neurovascular assessment. Anybody who's having problems with feet or like legs and they're having casts or amputations of arm, whatever, all of those things, surgeries on your arms, your legs, we're thinking about neurovascular. Those, they say 5 Ps, but there is 6 because there's pulselessness, right? Parasynesthesia, paralysis, pain, polycythemia, and pale or pallor. So those are the things that we're looking for in that neurovascular assessment. That is our priority when someone has an amputation. And it does say in the question, identifying complications. Well, problems can include hemorrhage, infection, skin breakdown, right? Because we just removed a limb. Phantom limb pain, which we talked about, is that pain perceived in the amputated limb and the unaffected limb, and that's due to the severing of peripheral nerves. And even joint contracture, which is kind of like tightening of the joints. So they're very stiff, they don't really move. And, depending on where the amputation is, right? If it's like just below the knee might not be moving as much, and that can cause stiffness there. Other things, right, when we're talking about goals, is relief of pain, right, like changing positions, making sure we promote wound healing. They could have altered perception of body image, so we want to make sure they have realistic goals and listen to them and have an accepting environment, and them looking at, feeling for, and caring for that residual limb would show really good signs that they're accepting it, right? Independence of self-care and restoration of physical activity. So they're using assistive devices, right? They're using range of motion exercises. And as they're healing for proper positioning, we don't want to do abduction, right? So we don't want to go towards the midline. We're going away, and we want to do external rotation, which is the exact opposite of what you do for hip fracture patients. So I just kind of thought that was pretty interesting. Okay. The next question is to identify emergency management of a client with open fracture after an accident. So Dr. Remy said if they have a wound, right, which they're going to have because it's an open fracture, this is someone who's coming into the ED, we want to apply pressure to stop any sort of bleeding, clean it and cover it. So know that you're going to cover it, you're going to put a splint on it, and you're going to immobilize it, okay? Those are the 3 things that I would know. And if you actually go to one of the slides on emergency management of fractures, what does it say to do? Mobilize the body part, splint the body part to help and keep the limb supported, to have neurovascular assessments, right? And cover it, when we have an open fracture, cover it with sterile dressing to prevent contamination. So immobilize, splint, and cover. Know it like that for emergency management with open fracture, okay? All right. The next question is to identify causative factors of hip injury, specify clinical treatment for joint manipulations, and specify clinical complications that may develop. So she said that the doctor may do joint manipulation such as casts or splints, and complications could include dislocations and compartment syndrome. Now, one thing that I want to point out is I went to the textbook and it said that causative factors for hip injuries have to do anything that usually results from falls. It's typically patients who fall who have hip injuries, and that can be due to weak muscles, slower reflexes, osteoporosis, and poor vision, right? Gait and balance immobilities, things like that. Medications as well, like those antihypertensives, right? Because orthostatic hypotension, things like that, they could be at risk for falls. Now, if they're going to get a brace or a splint or a cast, right, we always want to get that good general health assessment, but we always want to monitor for neurovascular status. Our priority when it comes, like I said, patients who are getting splints, braces, casts, if they got amputated, right, if they had a surgery, we want to have a neurovascular assessment, especially on those extremities, right? So we're looking for that pain, the pallor, the pulse parasesthesia, paralysis, and polycythermia or coolness, which is not on there, but it's a part of it. So when they have that procedure performed, right, it's going to be the first every hour for the first 24 hours. Neurovascular assessments. We want to do peripheral circulation checks like capillary refill, looking at edema, color, looking at motion, right? But that's basically the P's, right? If you know your P's, you know what you're looking for. It would be a very good select all that apply, right? Looking for sensations, that's that parasesthesia, looking for paralysis, that or weakness, right? Looking for that peripheral circulation, that pulselessness, things like that, right? We want to treat any sort of abrasions before the cast is applied, making sure that, they know the procedure and things like that. Now, there's also management of a brace, class, or splint. I'm not going to get too much into it because she didn't mention it, like how to handle the differences because we're talking about more like a hip injury. Just know that a plaster cast takes about 72 hours to dry, and that's the one that you handle with your palms, whereas a fiberglass cast dries within 30 minutes of application. And if the cast gets wet, fiberglass are usually water resistant, but we still don't want to get water on them. They want to dry it by patting their cast, and they want to dry it thoroughly so that you can prevent skin irritation. And you could even use a blow dryer and a sweeping motion for like an hour to dry it as well. But like I said, always priority your 5 Ps, right? Of course, yeah, turning, repositioning, looking for signs of infection, right? If they have swelling, elevate. The cast and have ice packs, things like that. And we know that complications, because they're going to be put in some sort of cast, splint, would be acute compartment syndrome, disuse syndrome, and pressure injuries. So compartment syndrome would be a problem with all of those 6 Ps. So if you see, right, if they say pain, parasesthesia, they're having pulselessness, they're having burning, tingling sensations, which is that parasesthesia, that things they're the site is pale. All of that would be signs of acute compartment syndrome, which is ischemia or severe compromise to blood flow due to having an increase in pressure in a confined space. And a cast is pretty confined, right? If we see this, we need to notify the doctor immediately, okay? The next thing is pressure injuries. If the cast is not applied appropriately, they can have pressure injuries. So if they report hot spots and like really tightness in an area, they might have a pressure injury, so we need to be careful over that. And we want to put any dressings over any exposed areas of skin. And they might try to cut the cast to open it to see where the pressure injury is. The last is disuse syndrome, right? They could have muscle atrophy and loss of strength or muscle weakness as a result of just not being able to use that, let's just say it's the forearm that they broke as much. So, isometric exercises, muscles setting exercises, quadricep exercise, anything like that to help reduce muscle atrophy and maintain strength. Another thing is for someone who's in a cast is that we want to pad the edges of the cast with like tape or moleskin so that it doesn't irritate the skin, and never try to put anything inside the cast. Like if it's itchy, don't tell them, don't try to stick anything into it. And they need to report any signs and symptoms of swelling and things, anything that signals acute compartment syndrome, right? All of that. Any questions?
Good.
Okay. Okay, so the next thing is interventions for a patient post-operative foot surgery. Now, always 6 Ps, right? And always, if they have edema, ice, elevate. So priority, neurovascular assessment. You want to relieve pain and swelling, elevate the foot, ice packs, and oral analgesics. We want to improve mobility, so weight-bearing exercises as prescribed, right? Whether it's full, partial, or no. And she said no weight-bearing would be crutches. Make sure they know how to use assistive devices, and we want to make sure they're safe, right? We want to prevent infections, keeping everything clean and dry. If they have pin or wound care, make sure you do that and look for signs and symptoms of infection like redness, swelling, drainage, odor, or an increase in temperature. But once again, priority doesn't matter. It's always the P's. The next question is to identify food items that promote calcium absorption. So that includes vitamin D rich foods, egg yolks, salmon, liver, green leafy vegetables, fortified cereals, and fish. I did come across a course point question that said foods that increase calcium absorption, and the answer was like vitamin D fortified cereal or fortified milk, something like that. So I would just say look for something like that. I think something like that could be a potential question. Okay. The next question is to list diagnostic imaging for a patient with low back pain. So think Dr. Remy said X-ray, MRI, CT, and a DEXA bone scan. The last question, or I think it's the last question. No, it's not. Okay. The last question is, or the second to last question is provide patient teaching of a client following a hip replacement and assess for potential complications. Now, we know for these patients, we do abduction where they sleep with pillows between their legs. They avoid crossing their legs and avoid bending at the waist because that's going to increase the risk for dislocation if they do those things. So we want to avoid crossing at the legs and avoid bending at the waist. Put the patient in really high seat, right? And a high toilet seat, and make sure the hips are always higher than the knees. Now, once again, if they're going under a hip arthroplasty, priority is neurovascular assessment, and after surgery, priority is still neurovascular assessment. Other complications could include bleeding. If we remember, we never change the first op dressing, dislocation, thromboemboli, infection, and even pressure injuries, right? So the goals include we want to prevent any sort of complications like infections, emboli, dislocation, wound infections, and we want to relieve any pain and make sure we have a stable joint. So once again, right? Correct positioning, keep the hips in abduction when turning, transferring, no internal rotation, right? We want to have external rotation for these patients. We want to have limited flexing of the hip, less than 90 degrees. We want to have the knees apart, put a pillow between the legs when sleeping. The legs should never cross inwards, never cross their legs, never bend forward, avoid bending forward to pick up an object, use a high-seated chair and a raised toilet. Do not flex the hips to put on your shoes or anything, right? These patients should begin walking as soon as they can to prevent problems like DVT, pulmonary emboli, things like that. Post-operatively, they could have drains, that JP and hemovac. We want to monitor the drainage. 200 to 500 milliliters in the first 24 hours is normal. And in 48 hours, that Jackson Pratt or hemovac should have less than 30 milliliters in 48 hours, okay? And remember, these need to be compressed to drain it, to open it, and everything. We want to prevent infections, right? So we want to watch out for infections, have good hygiene, have prophylactic, maybe compression stockings, anticoagulants to prevent DVT, make sure we get them moving to prevent DVT. And yeah. And they could even use reachers to help aid in getting things too. The last question is to identify the causative factors and clinical manifestations of a client with compartment syndrome. We already talked about compartment syndrome, so I'm not going to get into it. Just know if you're looking at your 6Ps, if they're having pain, pulselessness, parasynesthesia, pallor, coolness, paralysis, in that area, right, of their cast. They're feeling it like they're feeling all of these things because they're having that compromised blood flow. That signals, uh-oh, we need to notify the doctor. And for management, I also want to point that I found this from the textbook is that when they have acute compartment syndrome, we want to keep the extremity at the level of the heart, not above the level of the heart. And they might remove, like, they might open the cast a little bit, like by bivalving it, like cutting it at the side, just to help relieve the pressure so it doesn't get worse. Any questions about any of that?
No.
Okay, we're getting there. Slowly but surely, we're getting there. Okay. So now we're on cardiovascular. The first question is to identify abnormal cardiac rhythms like sinus brady, sinus tach, all of those. Now, I remember she had a similar question outlined on one of the outlines for cardiac, and it basically, the question just had to do with what like parts of the EKG mean. It was like the P wave, we know it should be the PR interval specifically should be 3 to 5 boxes, and every box is 0.04 seconds. So basically, it should be in between 0.12 and 0.20. The QRS complex indicates the heart rate, and she also mentions that sinus tachycardia would be a heart rate between 100 and 150. Greater than 150 would be something like supraventricular tachycardia. But I think this is just going to be an interpreting an EKG question because the way it's worded is exactly the same way it was worded on the previous one, and it wasn't related to a specific cardiac arrhythmia. The next question is provide and assess clinical management of a client with AFib. Focus also on medications for a client with AFib and the side effects. This looks also exactly like the question from the previous outline. So things that Dr. Emmy said for that specific one, I copied it because there was more in that one, was assessment includes like a 12-lead EKG, vital signs where we're going to see a high heart rate, a high blood pressure, risk factors for stroke, because remember, AFib clients, the treatment involves looking for giving anticoagulants and controlling heart rate, and that's because they're at risk for clots, especially ischemic stroke, right? So another thing is that if you have diabetes, that could increase your risk for arrhythmias and AFib. So for these patients, we want to control heart rate and we want to teach them how to take their radial pulse. And anticoagulants, we want to teach patients how to report bleeding and have bleeding precautions. So they're going to be taking a lot of antiplatelets and anticoagulants, maybe things like aspirin, Coumadin, right, where we monitor that PT and INR, right, statins, digoxin, calcium channel blockers, maybe amiodarone as an antiarrhythmia, right? But remember, digoxin toxicity can cause arrhythmia, so we want to make sure we check that apical pulse for 1 full minute and hold if the heart rate's not between 60 and 100. And if it's really bad, the atrial fibrillation, they're really unstable, right? And they're having some alterations in mental status, you do cardioversion for them, not defibrillation. You defib with VFib, okay? And you cardiovert when a patient is alert. If they're unconscious, that's when you do defibrillation. Just for your own knowledge. So there's a lot of risk factors, not going to go into everything, but one of them could be diabetes, and we know that could be a cause of AFib. We know that for AFib, we're looking for fibrillatory waves. We're looking for a really high heart rate. There's going to be no discernible P waves or PR interval. That's a key thing. No PR interval, no P waves. They're going to be fibrillatory. Everything else, like QRS, will be normal. T wave, all that's going to be normal. But the P wave, there's going to be no P wave, no PR interval. Okay. The next question is to provide education for a client with an implanted cardio defibrillator. Now, I know there's Dr. Remy's notes there, right? But I'm just going to go through what the textbook said because there's like more in there. For patients who have an ICD or defibrillator, they need to check their pulse daily. Any really sudden slowing or increasing a pulse rate could indicate malfunction. Dizziness also indicates implantable cardiac defibrillator potentially failing and having malfunction. So we want to watch out for changes in pulses and dizziness. Okay, we want to avoid infection at the site. So once again, especially if it's newly implanted, it needs to be, we want to leave it uncovered, but we need to check for daily redness, things like that, and checking temperature every day if it's newly implanted. And generally, when just having this in general, they need to avoid having really tight and restrictive clothing. And we initially, because it's still an open infection, if it's just a new, like newly implanted ICD, no soaking in tubs or lotions and creams, none of that. Now, activity restrictions would include not lifting the arm above the head for 2 weeks after it's been put in, especially no heavy lifting for a few weeks. They can never do contact sports. They have to always avoid large magnetic fields like MRIs. No. Security gates at airports, they can do hand searches, not a handheld device search, a hand search. Don't get, even if you see hand, it says handheld. No, a hand search. They should have an ID or something like that that lets them know, hey, we have an ICD when they go places. The phone should not be in the same side as the ICD because it can interfere with it. Okay, but microwaves are safe and household appliances are not a concern. Okay. Another thing is if they have dizziness, they should call 911. They should maintain a log that records the discharges. In other words, how many times they feel the ICD shock, right? Another thing is we want to warn family and friends that if the ICD does go off, they could also feel a shock if they're nearby and touching them, right? They should have a medical identification bracelet. They should carry that around all the time with the model number, where it's inserted, things like that, so people could know. And yeah, that's pretty much it for the ICD. Any questions? Okay.
So far, so good.
All right. So list medications that improve heart failure, know the route, class, and indication. She did mention that the ACE inhibitors is our priority. So maybe that question comes back. So keep that little thing in mind. But other medications include digoxin. We already talked about digoxin. We talked about taking the apical pulse for 1 full minute. Other things include teaching, patients how to take their own pulse and looking for signs of toxicity, like hypokalemia or low potassium levels can exacerbate digoxin toxicity. Bradycardia, they could have arrhythmias. They could see halos and have disorientation as well as nausea and vomiting. Diuretics, blood pressure. We always got to look for that, and electrolyte imbalances. But loop diuretics, like furosemide, can cause ototoxicity. So we want to tell the patient if they have ringing in their ears or experience hearing loss to notify that immediately. And because diuretics are removing fluid, they make you pee. They need to watch their urine output and take daily weights as well as monitor their blood pressure. And they need to have electrolytes checked, right? ACE inhibitors, the priority for heart failure. But the problems that they can cause is angioedema and a dry hacking cough. So we want to monitor for that. If they take that, they shouldn't be taking this medication anymore. And because it's a blood pressure medication, we monitor blood pressure. And ARBs will be the alternative for ACE, right? Metoprolol or beta blockers, also an antihypertensive drug. So we want to watch blood pressure, but because these are beta blockers, right, and they block those beta ones, they also lower the heart rate. So the patient needs to also monitor the heart rate as well as their blood pressure while taking this medication. So if they have bradycardia and they have hypotension, they should not be taking this. Also, asthmatics, like asthma patients and diabetics need to be careful with taking this. Diabetics, because beta blockers mask the signs and symptoms of hypoglycemia, and because remember, beta blockers block that beta too, so instead of causing bronchodilation, they cause bronchoconstriction, so this is not good for asthmatics. There's other medications, I'm not really going to get into those. Those are just extra, but the other ones are made. Okay, the next question is to develop management goals for a patient with complications of heart failure. So We want them to, I would focus mainly on these points because they're the ones that Dr. Emmy specifically mentioned. So, management goals for heart failure include promoting a healthy lifestyle by telling patients to take their meds. They have a decreased cardiac output, so as a result, we want to increase their contractility with things like digoxin, and we want to lower their risk of hospitalization. I would focus on those 3 points, as well as, right, they're going to have fluid restrictions between 800 to 1,500 milliliters. We should have daily weights and strict INOs. Because remember, they could have pulmonary edema, right? So they're going to have fluid building up there, which would also show signs in the like increase in weight, but also they could have weight gain from just fluid building up in their body if they have right-sided heart failure. So it all depends, but I would definitely focus on those. But other goals for heart failure include, right, promoting activity and tolerance, because remember, they could be activity intolerant. So we want to do activities that are going to help conserve energy, right? Manage and relieve symptoms of fluid overload. That's why we do our daily weights and INOs and restrict fluid to 800 to like 1,500 ml, as well as restricting sodium, right? And they should be taking their pulse for 1 full minute a day. We want to decrease any anxiety. We want to encourage them to verbalize, their decisions, have them influence their decisions, and educate them about the therapeutic regimen, right? If they're taking diuretics, don't take it too late, right? That their diet should be low in sodium and that have fluid restrictions, tell them what signs, symptoms to watch out for, and things like that. But once again, I would focus on that we want to lower the risk of hospitalization, that we want to increase the contractility, and we want to promote a healthy lifestyle for these patients. Okay. The next question is to identify overall goals for a client with heart failure. Now, Dr. Remy emphasized here improving functional status of cardiac output, extending survival, and relieving symptoms. So I'd also focus on those things. And remember, right-sided heart failure affects the body. So we're thinking about edema, we're thinking about jugular vein distension, we're thinking about splenomegaly, hepatomegaly, weight gain. And left-sided heart failure affects the lungs. So we're thinking about pulmonary congestion, we're thinking about crackles, dyspnea, a low SpO2, maybe pink frothy sputum as a result of pulmonary edema. They could even have oliguria, and that's because the left side sends blood out to the rest of the body. So if that's having a problem, the kidneys take 25% of the cardiac output, so you could have oliguria as well. Okay. The next question is defining the pathophysiology of peripheral venous and arterial deficiency. Now, venous insufficiency would be related to Virchow's triad, which I'm probably saying it wrong. It's endothelial damage. It's also venous stasis and altered coagulation. Arterial insufficiency is caused by stasis and ineffective tissue perfusion. Now, peripheral arterial disease, we have to think about intermittent claudication, which is pain when they're walking, but it's relieved by rest. They have ulcers with regular borders. Their ulcers are going to be black and necrotic due to that lack of perfusion. They're going to have hair loss on their toes, pulselessness. Their skin is going to be cool and dry and rubbery. They're going to have pallor, and the legs need to be dependent. Whereas peripheral venous disease is going to be dull, aching pain. They're going to have ulcerations with irregular borders. The ulcers are going to be beefy with red on the outer aspect of the ankle. So you usually see on the ankle the venous ulcers, whereas arterial is going to be more on like the toe, like the big toe. Pulses are going to be present, but they're going to be hard to palpate because of the edema. They're going to have warm skin. It's not going to be cold because the circulation is not affected. It's a venous problem. The ulcers are going to be yellow and brown, and the skin color can be more yellow-brown, whereas it's going to be pallor for arterial, right? And legs are going to be elevated with peripheral venous disease or peripheral insufficiency, venous insufficiency, I should say. Okay. The next question is to identify clinical manifestations of a client with hypertension and provide patient teaching, assess and provide clinical manifestations of hypertension, and list antihypertensive. So, education obviously is promoting lifestyle changes such as reducing salt intake to no more than 2 to 3 grams, monitoring their blood pressure regularly, teaching them about the dose, route, and side effects of their medications, exercising for 30 to 40 minutes a day, and referring them to a dietitian. Now, I'm not going to get too much into, hypertension, but we do know typically, depending on which ruling you're using, like which rating rubric, but we know at least 140/90 or greater is definitely hypertensive, right? And that usually they're not going to present with symptoms other than elevated blood pressure, but as it becomes prolonged and not treated, they're at risk for retinal hemorrhaging, renal damage, heart attack, and stroke. Okay, that's why we also said, hypertension or having high blood pressure was a risk factor for stroke as well. So we need to be careful with those things because hypertension can cause stroke, but hypertension is contraindicated if you need to give a TPA for ischemic strokes. All of those things, right? And yeah, other things is make sure you take your blood pressure properly, like having it at the level of the heart. They don't exercise, smoke, or drink before, and they don't have their legs closed. And we get a good an appropriate blood pressure cuff size, and we confirm always, we don't just assume that the first blood pressure reading, this is a new client who doesn't have a history of hypertension. They have hypertension because it's high this one time. You have to confirm it with at least 2 readings. Okay. And yeah, like I said, I'm not going to get too much into everything else, but we know that they shouldn't have symptoms. And if they do, if they're showing signs of like retinal hemorrhage or renal insufficiency, signs of stroke or heart problems, huge thing, right? And we basically said, right, DASH diet or low sodium diet, things like that. And exercise and all of that dietary and lifestyle changes is really important for those patients, as well as taking their medications. The next question is to assess and provide nursing management of a client with EKG changes and complaints of chest pain from um, a percutaneous transluminal coronary angioplasty. So we know that we want to give nitroglycerin for pain, right? We also want to look at the EKG to see if there's any ST elevation, right? Are they having an MI? We want to notify the doctor. We could do things like Mona, morphine, oxygen, nitroglycerin, aspirin, and vital signs, okay? So when we see, a patient who has chest pain, right, and they're having that, we want to help relieve that ischemia by giving them nitroglycerin and then giving them things like oxygen and such and so forth, like all of those things that we want to look for, right? It really just depends on how the question is worded for this type of question, but definitely know we're looking at Mona as well. Okay. The last question is defining the pathophysiology of nitroglycerin and provide nursing education to a client receiving nitroglycerin. Now, nitroglycerin, right, we use it for pain, especially chest pain specifically, and it reduces that demand on that myocardium. It reduces the preload, it reduces the afterload, and it reduces that oxygen demand, which is going to help with that ischemia, right? And it's a vasodilator, which means they're at risk for orthostatic hypotension. They could have a headache and feel flushed, right? So, what we tell our patient is that they'll take it sublingually, right? They can't take more than 3 and they're 5 minutes apart, right? So, if by the second one, if they need a second one, if it's still unrelieved, they should go immediately to the hospital, right? The medication should be kept in a cool and dark place. And we want to teach the patient that tingling sensations and warm sensations under the tongue while taking this is normal, and they need to monitor their blood pressure because of hypotension. Does anybody have anything else to add or any questions about anything we spoke about? Okay, then we're almost done. We're almost done. Okay, so now we're going to go into respiratory, which is chapters 19 and 20. The first question is to identify appropriate nursing management for a client with fever and chest crackles. So, things that we want to think about is they're going to get a chest x-ray because we're thinking fevers and chest crackles. Could this be pneumonia, right? Like what's going on here? Are they having fluid volume excess? Who are they having an infection? Like what's going on with this patient? So we want a chest x-ray. And she specifically said for a sputum culture, first thing in the morning, no eating, no drinking, no water, no nothing. Okay, that's when you want to take your sputum culture. I feel like the question will be something related to that. So I would keep that in mind. Okay. The next question is provide nursing intervention for a client following a bronchoscopy. I'm saying it like that. I'm probably saying it wrong, but that's fine. Post procedure. This is something that's going through their throat, right? So our priority after is assessing gag reflex and if they're able to cough. Okay, that's our priority post-op for someone who had a bronchoscopy. Okay, or bronchoscopy. Maybe that's the word, but that's what we want to do, okay? Because if they can't do that, they're at risk for aspiration, which means they're at risk for an airway problem. Not very good. Okay, the next question is defining the pathophysiology for a client with community-acquired pneumonia. So, it's still pneumonia, right? So we know that the lungs could have crackles, so they're going to be diminished. So we want to auscultate the lungs, right? If they have too much fluid, there might be aortic thoracentesis. We want to check ABGs because of the hypoxia as a result of all that fluid in the lungs and things like that. The level of consciousness, right? And a chest x-ray, right? Because we're looking for signs of fluid in the lungs. Now, specifically, we know like pneumonia will have things like fevers, chills, right? A low SpO2, things like that. But pneumonia in general is inflammation of the lung parenchyma or the alveoli, which can be caused by different microorganisms like viral, fungal, mycobacterial, regular bacteria. But community acquired is when you get it within the community setting 48 hours post-hospitalization. So within that 48-hour period after coming out of the hospital, going back into community, you can get it. Now, this increases with age, and it's typically caused by streptococcal pneumonia is the most common cause. It's blood-borne. It could lead to bacteremia, so they're at risk for hypoxemia and cyanosis, and the blood cultures that we'll draw will show they're positive for Gram stain. So, and it could also be viral if it's through infants and children, but I would know the most common cause is streptococcal pneumoniae. And yeah, so like I said, we know pneumonia, we know that it's respiratory, so we know our management is going to include respiratory management, right? Like oxygen saturation, vital signs, lung sounds, right? Antibiotics, we know this could be bacterial and it's most commonly bacterial. Blood and sputum cultures, right? ABGs, because they are going to have tachypnea, so they're at risk for respiratory alkalosis, and if it worsens, they can go into respiratory acidosis. And they have like things like ineffective oxygenation, potentially ineffective airway clearance, activity intolerance related to hypoxia. So we have to think about all of these things, as well as risk for fluid volume deficit related to a fever and that rapid respiratory rate and impaired gas exchange. Remember, this affects the alveoli, any type of pneumonia. Okay. The next question is to perform a nursing assessment in a client with respiratory failure and provide assessment parameters for the nurse to monitor. So vital signs, breathing patterns, ABGs, lung sounds, level of consciousness, right? Oxygen saturation, giving oxygen, all are respiratory, right? Elevating the head of the bed, things like that. Okay. The next question is developing a plan of care for a client at risk with impaired gas exchange. So what do we want to do? Once again, elevating the head of the bed, typically 30 to 45 degrees, giving oxygen, vital signs, and teaching breathing techniques, things like pursed lip, deep breathing, and centrospirometer, all of that, okay? Respiratory interventions, got to think about. They pretty much repeat. The next question is develop a plan of care for a client being mechanically ventilated and lower respiratory tract disorders. So Dr. Remy was saying they have an endotracheal tube, right? There's going to be, we want to have maintaining that cuff pressure. We fill the cuff with 10 milliliters of air, and we need dressing changes, still respiratory, so oral care and suction PRN, right? We want to have infection control. Typically, they might do some oral care with like fluorhexidine, things like that, right? Cuff pressures need to be checked and maintained. If it's too low, they're at risk for aspiration pneumonia. We want to monitor the peak flows, oxygen saturation, things like that. Remember, right? This is a ventilator, so there's ABGs. We're looking at lung sounds. We're only suctioning as needed, no more than 10 seconds, right? And we always hyperventilate before suctioning. Oral care, maybe using that yank hour, elevating the head of the bed, right? Vital signs, cough reflex. All of this stuff is repeat, right? But of course, it's an airway. It's an artificial airway. So our priority has to be airway, okay? So nothing more than I can really add to that other than you need to always assess the lung sounds frequently, right? Like every 2 hours, suctioning as needed, chest PT, right? Things like that. Humidification to help remove secretions, mucolytics, bronchodilators, infection control measures. We already talked about all of this. And yeah. Okay. The next question is to list medications for asthma and follow the respiratory medications listed provided in class. Well, we know that she said albuterol is going to help alleviate airway obstruction. We know albuterol is a short-acting beta-2 adrenergic agonist, which simply means it works on beta-2, so it promotes bronchodilation. Albuterol works very quickly, so it's a relief medication. We give this to someone who has an acute asthmatic attack. So it can cause tachycardia, right? So they need to check the heart rate first. And that's because even though it's beta-2, it's really selective, it could still potentially affect beta-1, which is still high heart rate. We want to check oxygen saturation levels and vital signs before. We want to make sure that we also will tell them they could look to flush. And another drug that could be used as a rescue is an anticholinergic called ipratropium, and that's because it could cause that bronchodilation and it helps reduce secretions. Now, long-acting medications would include long-acting beta-2 adrenergic agonists like salmeterol and formoterol, and they're usually given in conjunction with corticosteroids like beclomethasone or prednisone to reduce inflammation. Because remember, asthma is an inflammation of the lungs that's causing that obstruction, right? So you always want to give the bronchodilator first and then the steroid. And that's because, one, you need the bronchodilator first to open up the airway. But the second thing is that the corticosteroids enhance the effects of the beta-2. So you give the bronchodilator first, then the corticosteroid that's further going to enhance the effects of that bronchodilator. We know that we need to taper down on corticosteroids and we want to monitor for bleeding, right? And they could have urinary retention. And usually, especially if it's a bronchodilator corticosteroid mix, always you want to rinse the mouth afterward, right? Because they can cause ulcerations. Another long-acting medication would be like montelukast or leukotriene and modifiers. They also reduce secretions and help with inflammation and things like that. I don't know if it's the last question. I lied. The next question is provide nursing management for a client with bronchiectasis. Dr. Remy said that bronchiectasis is basically this dilation of the bronchi and bronchioles that's usually due to cigarette smoking and it causes a lot of excess secretions. So doctor could order prophylactic, antibiotics. They'll have bronchodilators and mucolytics to help get rid of those secretions. They'll have chest PT, postural drainage, breathing exercises, and we could do suctioning, right? Now remember, think bronchiectasis, lots of sputum. So they have lots of sputum, lots of coughing, right? And that could cause, right, too much hypoxic. They're having dilation of the bronchi. So they're going to be hypoxic and they could have a little bit of a barrel chest, right? Management. The goal or the focus of it is to alleviate symptoms and clear pulmonary secretion. So we want to teach them about smoking cessation. That's going to help reduce some of those secretions and help with the pulmonary issues. Post-oral drainage, chest PT, right? Antimicrobial therapy, looking for signs of infection, and conserving energy. But smoking cessation is one of the first things that you want to teach them about. And remember, the goal is to alleviate symptoms by clearing pulmonary secretions. And we can do that through mainly the smoking cessation and the post-oral drainage and chest PT. Okay. Any questions about anything?
No.
Okay. The next thing or the next question is provide nursing education to a client performing breathing exercises. I feel like this is a question from a long time ago that's coming back. That's a select all. But it was what she said specifically, why do we teach patients breathing exercises, especially COPD? She said that we want to increase oxygenation and lung expansion. We want to prevent atelectasis or collapse of that alveoli. We want to have breathing exercises because they help with deep breathing and they help with controlling the width and depth of respirations and they help prevent air trapping. I would know it like that, right? Straight exactly the way that she said it. Other thing is I added a chart in my notes from it's chart 20-5 on patient education, and it says specifically for diaphragmatic breathing, the goal is to use and strengthen the diaphragm during breathing. And pursed lip breathing, the goal is to prolong exhalation and increase airway pressure through expiration, thus reducing the amount of trapped air and the amount of airway resistance. Just wanted to add that in there. Okay, the next question is provide nursing technique about the use of a metered dose inhaler. Dr. Remy said to teach the patient take a slow breath, deep breathe in, slow breath in, deep inhalation from the device, and activate the device dispenser to dispense the metered dose medication. So I found this on page 630 on patient teaching for a metered dose inhaler. So first thing you want to do, tell the patient remove the cap and hold the inhaler upright, shake it, have the patient sit upright or stand upright and breathe out slowly and all the way. You're going to place that inhaler in the mouth. Make sure you close seal, right, around the mouth. You're going to seal your lips around it, right? Then you're going to press in, breathe in slowly, hold your breath for 10 seconds so your lungs can get that medication. Slowly exhale, allow 1 minute in between the puffs. And then you apply the cap on, and if it has that corticosteroid in it, especially, we want to rinse the mouth after every puff, right? That's what we're going to want to teach them. The next question is prioritize nursing interventions with a client with bronchiectasis. Similar thing, right? We basically just want to, lots of secretions, post-oral drainage, right? They have that chronic cough, lots of sputum production. Primary goals, smoking cessation, post-oral drainage, getting rid of those excess secretions. The last question is indicate oxygen concentration that best meets the needs of a COPD patient. And we know 1 to 3 liters or 1 to 2 liters via nasal cannula. And that's because they're so used to being in such a hypercapnic or high CO2 state that oxygen is actually really toxic to them normally. So high oxygen levels would be like, whoa, what's going on, right? Like their body's going to freak out, which is why you want to use low concentrations of oxygen for someone who has COPD. Any questions before we do what I think is, oh no, it's not the last chapter. I lied. There's 2 more. Okay. Any questions?
No.
I apologize if this is taking longer than I.
Oh, thank you, Alicia. I really appreciate you for all this.
I'm happy it helps. I just realized it's like getting later, so like if you
Oh,
guys.
this helps a lot. I really am happy with.
Well, I appreciate that. There's not that many pages left. There's only like 7 pages, so we could get through this relatively quickly. Okay, the next chapter is chapter 12, which is oncology. There's going to be 5 questions. The first question is provide nursing education for a client to be screened for cancer, focus on primary, secondary, and tertiary. Well, we know primary is teaching, secondary relates to screenings, and tertiary is treatment. We know Primary means they don't have anything. We just want to educate them so they know what to do, like health promotion strategies. Secondary is they have risk factors for it, so we want to screen them. And tertiary means they have it or have a disease, and we want to help rehabilitate them and alleviate those symptoms so we go through with treatment. Okay. Question 2 is to provide nursing interventions for a client experiencing IV extravasation secondary to chemotherapy administration. This question came up 3 times, once on our quiz for this, once on our midterm, and it has to be the same question. So, if I'm guessing right, extravasation is going to cause 3 major things. It's going to cause tissue necrosis, leakage at the site, leading to slaw or slough, I don't know how to say it. And we want to measure the antidote for its effectiveness. Now, the antidote is dimethyl sulfoxide. Other manifestations of extravasation include warmth, swollen, red, necrotic, slaw, and examples of drugs that can cause this, like chemotherapeutic agents, are like vincristine. But I would know tissue necrosis, leakage at the site leading to slaw, and the antidote is measured for the effectiveness. I would just highly know that. Okay. The next question is to provide appropriate nursing interventions for a client with a GI bleed and a medical diagnosis of metastasis colon cancer. So basically for this question, she said the doctor will order a blood transfusion. I'm assuming it's packed RBCs, right? Once again, our priority for this is going to be if we see a blood transfusion reaction, we know to stop it. We want to assess vital signs, right? We want to ask them about their symptoms, and we always stay with the patients during that first 15 minutes of a blood transfusion because that's when you're most likely to see transfusion reaction. So if they have things like fever, crackles, shortness of breath, lower back pain, chills, itching, rash, hives, things like that, stop the transfusion, right? We should also have epinephrine on standby, especially if they're having like angioedema or something, right? We always want to send the blood back in its original tubing, and then we're going to set up a new line of saline connect to a new like IV bag, not an IV bag, like an IV tubing. But we keep the blood in its original tubing, in that Y tubing, and send it to the lab so they could see what's wrong, right? And we know that we only give blood with normal saline. Anything else would crystallize the blood, not be good. Speaking of which, the next one is to provide clinical manifestation of a client with a blood transfusion reaction, NGN. You already said priority, stop the transfusion, right? We know we can only give normal saline with the blood transfusion. So any other IV fluid would not be acceptable, right? We know that we need to take vitals, right? Before the transfusion and after. Before, we need 2 nurse verification, right? We need to look at the policies. They have a good IV site, right, of 18 to 20 gauge, testing the blood compatibility, like a type-in screen, looking at the bag, right? Making sure the bag doesn't look weird. During the transfusion, we know that blood cannot be transfused for more than 4 hours. It puts the client at risk for fluid overload. They needs to have Y tubing. We need to stay with the patient for the first 15 minutes, right? And monitor vital signs, right? We already talked about the manifestations, so I'm not going to get into that. And yeah. The next question is providing nursing education for a client undergoing chemotherapy for malignant tumor of the neck. So we know that chemotherapeutic agents can cause things like impaired nutritional status, wet versus dry discriminations, dysphagia, neutropenia, and we want neutropenic precautions, alopecia, right? Because it causes like bone marrow suppression. So they might be a little bit anemic. We want to put them on bleeding precautions, and they have stomitis. But remember, this is a tumor of the neck, right? If they're having a tumor of the neck, right, and they're getting radiation there and chemotherapy there, we know that they're going to have impaired nutritional status because of the fact that they're not going to really be so comfortable eating if they're getting pain there, right? If they maybe have a risk for stomitis in that area. So all of those things, come into effect. So got to think about that, right? So for that patient, we really got to think about poor nutrition. right? I'm not going to get into everything, but just know that with neutropenic precautions, right? No visitors, no crowds, no fresh foods or vegetables, no fresh fruits or vegetables, and no flowers. And always for any patient who's immunocompromised, you should never go near litter boxes or bird cages. And that's because they're filled with like bacteria and stuff. And I think it's called like toxoplasma, something like that they can get from litter boxes. She mentioned like radiation and things like that. I would review maybe just the radiation precautions. I'm not going to go too much into it now, but I don't think it's going to be on there, but just in case, because she was mentioning as she was talking about like, having the sign on the door for radiation precautions, 6 feet away, no more than 30 minutes a day, right? Private room, limit visitors, no pregnant woman, and if it dislodges, forceps, and have a lead apron, right, for radiation precautions. Internal radiation precautions. External, we know that they're going to have markings on their skin, so just make sure not to wash them off. That's like the key point for that. Remember, malignant tumor of the neck, impaired nutritional status, or problems with eating, okay? The next question is provide appropriate nursing interventions for a client with a diagnosis of gastric cancer and unable to tolerate food or fluid intake. If the keywords unable to tolerate oral food or intake, which means they're going to need to have a total parental nutrition. We said insufficient oral or enteral intake and inability to ingest food orally or enterally is going to put them at a need for TPN. So we know it's a central line that we need that sterile technique, right? During dressing changes, nurse and patient has to both wear masks, monitor signs for infection and hyperglycemia. So we need a capillary blood sugar. Know that, right? Okay. Next question is to perform a physical assessment of a client with a diagnosis of prostate cancer and include specific lab values. So Dr. Remy said that the PSA, that's a tumor marker for prostate cancer, normal is 4 to 6. Higher than 6 means they can have the cancer, right? So we want to learn about patient history and risk factors. I think this is all important, the next things I'm going to share, because it helps really like summarize like what's going on. So for prostate cancer, risk factors include a diet of lots of red meats or dairy products that are high in fat, having a family history. African American men have a higher risk of prostate cancer, as well as increasing age of greater than 65. Manifestations, prostate, right? The prostate is going to, let's just say it's becoming really enlarged. It's going to block and have problems with urination. So you got to think prostate, urine, prostate, urine. The same way you think kidneys, urine problems, you have to think prostate, urine. So it's going to be so large that it's going to obstruct urinary flow. So they're going to have difficulty urinating, urinary retention. They're going to have painful urination or dysuria, maybe even hematuria. So we have to have a urine analysis for these patients to look for blood, and they could have painful ejaculation. Nursing management is going to include family history and nutritional history, history on urine output, a urinalysis to detect blood in the urine, tumor markers, and maybe TURP for bladder irrigation as well. Now, I think this question and the next question are going to be the questions that we had from quiz 2 because they're worded exactly the same way from the other outline. So just keep all of these things in mind, okay? The next thing is to assess clinical manifestations of a client with acute prostatitis, I'm saying it like that, and provide nursing management. So, same sort of thing. It's inflammation of the prostate, but it's due to a bacterial infection. So, in addition to having urinary problems, they're going to have a fever, right? A fever and chills. They're going to still have urinary changes and ejaculation pain. For this specific question, and I remember this because I copied it from the last quiz, well, another quiz outline. It's going to be medications such as antibiotics, right, to treat that bacterial infection. That's what causes this. And tamsulosin of 0.4 milligrams to help with the blood flow because they could have also be pH, right? So you want to help with the urine output. We want to kill the infection with the antibiotics. We want to tell them to take the full course of their antibiotics. They need to follow up with their provider and tell them to urinate standing up because that's going to help alleviate pressure in that area. Any questions? Okay, so we're almost done. I apologize, like I said, for going over, but I do hope it helps because, I know it's a Friday and nobody wants to be listening to me all day on a Friday, so I am trying to hurry a little bit.
Thank you for listening. This is helping.
You're welcome. Okay, the last is like only 4 pages, so it's gonna be quick. So the first question in chapter 11 for shock, sepsis, and multiple organ dysfunctions is identify clinical manifestations of a client experiencing compensatory shock. So we know shock means decreased tissue perfusion, right? We know shock can be classified in 2 ways: fluid, decreased fluid, or like hypovolemic shock, right? Or distributive shock, shock due to vasodilation. Now, any other shock that's not compensatory shock is progressive, okay? Because compensatory shock means that the blood pressure is normal, right? It's going to be like 118 over 72. It's going to look great. Progressive shock is always going to be hypotension, right? Like 90 over 60, 80 over 40, whatever, a low blood pressure. Compensatory shock, right, is his body's way of saying, let me help increase the perfusion. Try to increase the blood pressure, but it's still going to be normal, right? And normal cardiac output. They're going to have tachycardia, tachypnea, cool and clammy skin, right? Because the body compensates by reducing blood flow in areas like the skin, the GI, and the kidneys. So if it reduces it to the skin, we're thinking cool and clammy skin. If it reduces it to the GI tract, we're thinking hypoactive bowel movements and hypoactive bowel sounds. And if we're thinking reduction to kidneys, we're thinking oliguria. They also could have confusion due to the altered perfusion, as well as respiratory alkalosis. Know that, okay? So that's what we're thinking about. Our priority in our nursing management has to do with treating the cause. What is causing the shock, right? Is it volume problem, right? Is it an infection? What's causing the shock, right? And figure it out and treat that appropriately, and assessing, the patient's consciousness frequently, vital signs frequently, urine output, capillary refill, respiratory rate, lab values. Okay? And we always want to clarify advanced directives with these patients, especially, as symptoms could be progressing. Assess and monitor the complications of a client receiving fluid replacement. Question number 2. Well, we know, right, if someone's getting too much fluid, right, what could they be at risk for?
Fluid volume overload.
Exactly, which means fluid can go in their lungs. So we're thinking about crackles. So we want to assess lung sounds, pulmonary edema, difficulty breathing, tachypnea, right? Bounding pulses, distended neck veins, signs and symptoms of fluid volume excess, right? But we're thinking about, right, if they're getting too much fluid, we got to think about lungs, right? We got to think about looking for crackles, looking for pulmonary edema. That's what they could be at risk for. Question 3. Provide nursing interventions of a client with progressive shock. Also focus on the type of medications used and proper administration of medications. So we know that progressive shock means compensatory mechanisms failed. No more normal blood pressure or cardiac output to try to help the body. Now it's, we need vasoactive medications that are going to raise the blood pressure and cardiac output, like epinephrine, dopamine, and norepinephrine. Now, she mentioned dopamine, which is why I went into this. So dopamine, right? It's one of those drugs that we need to verify with the dose with another nurse. We need to taper dopamine. That's because dopamine improves contractility, but it needs to be in a very strict range, because a slight increase can increase the cardiac output too much and put the patient at risk for arrhythmias, okay? So it needs to be carefully tapered and carefully titrated. It has to be on a controlled pump. We need to monitor vital signs, right? Because it's a sympathomimetic, so it's going to cause an increase in heart rate, increase in blood pressure, and monitor urine output, because dopamine has receptors in the kidneys and it can make you pee more, right? And we also want to monitor EKG. Why? Because as I said, it can cause arrhythmias. That's what I want you to know about dopamine, okay? Next thing, progressive shock. We're talking about compensatory mechanisms fails, blood pressure drops, lungs start to decompensate, decreased pulmonary blood flow, no more respiratory alkalosis. Now they're heading into metabolic acidosis. They have severe hypoperfusion. They don't have a MAP greater than 70. They don't have a glomerular filtration rate greater than 60. Greater than 60. things like that. So the manifestations for progressive shock include rapid, shallow respirations and a low blood pressure, typically of a systolic less than 90, okay? They have crackles and chest pain because a chest pain is due to that hypoperfusion and ischemia. They're having further decreased mental status changes, acute kidney injury, right? Because we said before in CompStore they still have oliguria, but now it's even worse because they're having continued hypoperfusion. They can have ulcers and GI bleeding and clotting. So management includes restoring the perfusion, respiratory support, right? That's one of our priorities, right? Nutritional support, ABGs, right? Because they're in metabolic acidosis, right? They can even lose consciousness. And they'll have increased CO2 levels as well, right? That's also why we look at ABGs, EKG monitoring, and mental status monitoring. Question number 4, list medications for client with cardiogenic shock. Pretty sure it's just going to be the inotropic drugs, right? Like dopamine, epinephrine, norepinephrine, or phenyl. I can't say it right now. Phenylprin? I'm sorry, it's not coming out. But cardiogenic shock is a progressive type of shock, right? So there's that low blood pressure and it's due to some sort of impairment or failure of the myocardium. So still has those, right? Like low urine output, cool, clammy skin, right? Hypoactive bowels, more heart manifestations like maybe jugular vein distension and muffled heart sounds because it could be due to things like left ventricular pump failure, heart failure. These are just extra things, but priority for cardiogenic shock is oxygenation for the heart muscles. That's your priority, okay? And then giving medications like we said, dopamine, dobutamine, epinephrine, norepinephrine, drugs like that, vasoactive medications. You could give nitroglycerin for the pain, but if it says an inotropic drug or a vasoactive, inotropic means it increases contractility of the heart. It's just a fancy way of saying what's going to increase my heart rate and blood pressure. If you see that, it's not going to be nitroglycerin or nitroprusside. Those are vasodilators. You need dobutamine, dopamine, epinephrine, norepinephrine. Okay. All right. The next question is define the pathophysiology of compensatory mechanisms and reabsorption and reattention of fluid in the stage of hypovolemic shock. Now, remember, this is progressive shock, but this is what she said. We are talking about the antidiuretic hormone and corticosteroids. These affect the kidneys and cause urinary retention. So think about it this way, right? When you have hypovolemic shock, right? Let's just say this is a person who's a burn patient, right? Or a hemorrhage. They're coming in. Their body's going to try to compensate at first, right? So what's going to happen is that antidiuretic hormone and the corticosteroids are going to increase to try to increase the cardiac output and perfusion. Antidiuretic hormone retains sodium and water to help increase blood pressure. That's why they have also urinary retention as a result because they're retaining onto that salt and water. They're not peeing it out. Okay. So I would know the compensatory mechanism. We're talking about antidiuretic hormone and corticosteroids. They're affecting the kidneys, right? And it's causing urinary retention. But no, it's from antidiuretic hormone and corticosteroids. But once again, hypovolemic shock, we're thinking about progressive. So it's still low blood pressure, cool clammy skin, tachypnea, rapid, weak, thready pulses, pallor, concentrated urine because they're not peeing that much because they're retaining it onto it from that antidiuretic hormone, okay? So the urine specific gravity is going to be very high. We want to treat whatever the cause is, right? If they're hemorrhaging, maybe we're going to give blood, right? If it's burns, we're going to give fluid, right? If we're going to give a colloid solution, we want to give albumin 5%, but dextran is contraindicated in hemorrhagic stroke. And hemorrhagic stroke, or really any hemorrhage. Hemorrhagic stroke, yeah, but any hemorrhage. And we are done. Is there any questions?